So, with the permission of the chair for the first session, sir, if you can, sir, should we start? So, I will invite for our first technical session on comprehensive service delivery models. First, please give a big hand for our chair, Shri Alok Saxena, Additional Secretary and Director General NACO. Our respected co-chair, Dr. UB Das, DDG NACO. Big hand for Dr. UB Das, please. Our esteemed panel. So first, I'd like to invite Shri Naveen Kumar, IAS, Project Director, Andhra Pradesh SACS. Thank you for being here, sir. Dr. Hemlata Thokchom, Joint Director, Manipur SACS. A big hand for Dr. Hemlata, please. Up next, requesting our community representatives, Madam Apsara Reddy and Ms. Abhina Aher to please join us. Ms. Abhina and Ms. Apsara. Thank you for being here. And finally, Dr. Bitra George, Country Director, FHI 360. Thank you, Dr. Bitra. So we have 3 speakers in this session. Each of the speakers will have 15 minutes each for a presentation, after which we will have comments from the panel members. We'll also take questions from the audience, moderated by the chair and co-chair. And then finally, we will close with remarks from the chair and the co-chair. So I will invite our speakers. Our first speaker is Ms. Simran Bharucha. If you can please take a seat as well. And Dr. Subhash Ghosh, who's project lead with Accelerate, presenting on adolescent-friendly centers. And Dr. Manish Bamrotia, who is technical director with Accelerate, presenting on the TAL Plus Integrated Health Center for PLHIV. Sir, I will now hand over to the chair and the co-chair for the conduct of the session, which is to begin with the presentations and then further discussion. Sir, over to you, please.
Thank you, Aditya. So we start the first technical session, and the first presentation will be made by my dearest Simran. So go ahead and do that.
Sorry for those technical glitches, but once again, a very, very good afternoon. Still morning? Okay. Sarah, don't worry, sir. But yes, good afternoon to everyone. The morning inaugural session did speak a lot about Mitra Clinic, and I'm sure you all may be wondering, what is Mitra Clinic? Nah, that's not reality. I'm sure you all know what is Mitra Clinic. And let me run you through a journey which was actually seeded by the community. So I'm not the one who's supposed to be taking the credit. Though you all gave me, I'm really very thankful to you all, but the actual credit goes out to my Mitra Clinic managers who are sitting out there. Can I have you just standing and wave out? That's my force. My Rachna, who is actually managing the entire Telangana state as a state expert, trans state expert. So she's the one to be credited. Yes, without them, this would have not been possible. And what is not possible, it will be seeing today, right now. Though you got the snippets, beforehand. So let me take you all through a very beautiful journey of HIV. As we all know, the late 80s, when 86, when the HIV hit, and where we are after 35, almost 35 plus years, where we are right now. And though we have significantly, very promisingly showing the world that we have improved, I think we really deserve a huge round of applause for ourselves, because we are the one who really work at the field. And I think that is why we have this beautiful, uh, you know, high, huge numbers. We have brought it so down. And those people who are actually living with HIV, we are ensuring that they are put on the treatment, they are put on the medicine, and that's how we further move on, you know. As you see the data, we are still yet to cover. The transgender community is yet not there at that mark where we are expected. We wish we could reach to that 0.00. That's our goal one day that we intend to reach. But I'm sure with the space, with the speed that we are right now, one day eventually we will reach over there. But this is not possible without each one of your support. Because yes, we are community and we are this way. You know, we are indulged into high risk behavior, but that's our bread and butter. If you want to reduce our vulnerability, start addressing the needs of our community, the needs of our thing, that what we want. And that's what we managed to do in 3 small places, but yet creating a magnificent impact through the country, which we can really demonstrate. As I mentioned, this clinic, the Mitra Clinic, has a very clear objective of ensuring that we serve non-HIV services to ensure that we are reaching to HIV vulnerability reduction. And when we say that we go with as an entry point of non-HIV services, is we are tapping to the real needs. Now, my real needs could be money also. Yes, it is very important. But I'm sure we can't be doing that, right? We can't be giving money. But what are the priority list of services? At least we can look at that. And then, you know, by giving those services, by addressing those services, at least we can reduce the HIV vulnerability. I'm so proud that we are just 1 year old, more than a year old, but we have picked up on the field. We have picked up because we do not give any sort of tailored intervention or services. Our services go beyond the list. We go beyond the regimes. We cross the boundary. We push the boundary to an extent where our community feel good. Because most important for us is our community. The environment that we create within the clinics has to be enabling environment, has to be respect with dignity. Respect तो हर कोई किसी को दे देता है. जब dignity की बात आती है, तब अक्सर so-called hierarchies and scholars की परिभाषा बीच में आ जाती है. I feel very proud, standing behind this podium and addressing to you all, facing to you all. It's an empowerment that I have also gone through. 20 years behind, I was also a community person. I'm still a community. But my community comes with responsibility because people at that moment believed. Till today, they believe in me, and that's how we are functioning. I'm passing on my leadership to my clinic managers and to my entire staff, because they are the second line leaders who are coming up, in the market, and they are taking this journey ahead with me. I keep on mentioning the services, the services, the services. The services are nothing but the immediate wants of the community. And the community really demands that apart from HIV and STI, which we are very vulnerable, there are gamuts of other services which really makes us more vulnerable. If you are not going to address me by my preferred pronouns, I may not be wanting to come to your clinic. Yes, HIV ki khatre mein main hoon. Yes, I am on ART. But if you don't address me as she and hers, I may not feel coming to your clinic. And that is what we provide the services, the basic pronouns to the gamut of gender affirmation. Yes, we are converting the community's mindset of not going to the quacks, but actually going to the professional medical officers for their gender transition. And both ways, it's really very difficult because बहुत सारे लोगों ने धंधा बना दिया है और वो धंधे को हम लेवरेज कर रहे, कोशिश कर रहे ताकि हम वो धंधा को नीचे ले आए, उनके धंधे पे हम अटैक नहीं कर रहे, but अपना भी मकसद हम खोएंगे नहीं. That is what is the agenda of Mitra Clinic within the premises that we give services. My real progress is this. The constant check with the community where we actually get the feedback of what the community feels within the clinic is my progress. Yes, numbers are very important for our donors, for our national program. We do appreciate that. We do understand that. But if this is not there, how do you expect us to be giving that numbers? And this is what we get from our community when they walk into our clinics. Be mindful, we also cater the services to trans men population. Though we hear completely every time that only trans women are vulnerable, yes, they are. But trans men are also equally vulnerable. And that's what we do within our clinics. अगर previous slide नहीं होता तो शायद ये numbers मैं आपके सामने नहीं रख पाती. We are 1 year old. We are progressing. We are progressing in the right direction. We are ensuring that every life matters for us when they come down to clinic. These numbers that you see on your screens are remarkable numbers for a year and a month or two to be really showcasing. The HIV cascade versus the versus the numbers that we have really achieved in terms of registration is really varying because we have those X factors which actually bring in our community to our clinic. As we proceed further, we also are ensuring that we don't halt here and start taking the pats on our back. But we want to really, millify the Kanda with the national program and ensure that we walk together in each and every step of our life. We are considering to introduce PrEP, as you saw that just yesterday we started, distributing PrEPs to transgender community by our generous donor, John C. Martin, who made it possible for us. We are also ensuring that we start dispensing ART medicines from the clinic at the community level so that, the burden is less at the public health, but at the same time, the community does not feel discriminated or stigmatized when they walk within the premises. we are trying our level best, and there has been in previous years, in this year, we had a couple of visits by the Center of Excellence, AIMS, and NACO visiting our Mitra clinic to ensure that such kind of models are established as Center of Excellence within the AIMS hospital in Delhi. And this is just one step. Definitely, once we go further, and inshallah, we'll have all the AIMS throughout the country having this Center of Excellence established for transgender people. And last, I come back to the community again, that we want to ensure that we don't leave anyone behind. Because together we stand strong, we stand tall. Thank you.
Thank you, Simran. This Mitra Clinic work that we've been doing together for almost, I think, more than a year now, it's actually taken roots. It's again one of those models which can work, because as we know, it's a more investment intensive model. It can't be replicated everywhere. So इससे दो चीजें हमें करनी चाहिए, मुझे लगता है, जो आप हमें ज्ञान देंगी इवेंचुअली, या आपकी टीम ज्ञान देगी, कि कैसे हम इस मॉडल को थोड़ा इन्वेस्टमेंट लाइट, थोड़ा हल्का बना सकते हैं, है ना? मतलब नॉट दैट बॉम्बे की लैंग्वेज वाला हल्का नहीं, समझ गई ना? हाँ, तो कैसे हल्का बना सकते हैं इसको इन्वेस्टमेंट में, वो करने का है। और दूसरा कि इसको हम कैसे, अभी हमारी जो लर्निंग है कोविड की, सॉरी, आई मीन वी जस्ट burst into our own lingo, our learnings of the COVID pandemic, how we can use teleconsultation, though of course that human touch is not there, and you know that famous phrase of our friend Vivek may not be applicable here, but then still services can be delivered, and those of them who eventually want to travel can come. So my idea is that how we maximize return on investment on this in terms of more people using it. और दूसरा है कि इसको हम इसके लाइट मॉडल्स कैसे बना के और जगह रिप्लिकेट कर सकते हैं, वो एक अच्छी चीज है, लेकिन ये बहुत बढ़िया काम है। और आई ऑलवेज से दिस दैट while now we have an act for transgender people, there's a ministry which looks after full time the welfare of transgender population, but their health remains our business. And health also means when a tiny little one discovers the incongruence between the gender assigned to him by nature and how he or she perceives herself or himself. So उस स्टेज से हमारा काम शुरू होता है, क्योंकि सोशल जस्टिस तो बहुत बाद में आएगा, it'll come much later, but we need to build capacities, or maybe to the amongst the parents, amongst society. The child should not feel that okay, ajuba hai, all those things, and eventually taking them for healthcare, and initially it'll be counseling, and we know the entire drill there. So that's important, and that work will remain with us. Also, now in the pandemic, aging population, this is transgender, but this is other populations also, have a burden of NCTs. So while we can, take care of tuberculosis and of viral hepatitis, we must. But at the same time, if they are overweight, if they need replacement of knees, how in that direction, orthopedic, particularly we need to, because if somebody's taking ARVs, then it's impacting bones as well. So वो चीजें हमें साथ साथ करने की है, और सबको इकट्ठे करना है, वो मेरा मंत्र, never forget, breaking the silos. So when you do it for everyone. Okay, okay. So that's how it is. Now our next is Subhash Chandra Ghosh. Where is he? So come, he's talking on adolescent-friendly health centers for ALHIV. So that's again a very important topic for us, and how service delivery can be taken to adolescents. That's another extremely vulnerable population. I was on the sidelines having a chat yesterday with Dr. Sunil. That remember Vivek hai na? Yeah. So when he took us to their own center at uh, Hamsafar. What is the place called? Vakola. Vakola is not famous for anything else. You ask a rickshawala, he'll say, "Acha, wo jo Hamsafar ka clinic hai." So at Vakola, when he took us there, you remember that boy from Bhopal? So I was wondering sitting there that how come at the age of 19, though he was extremely gathered, he was there, but how he became positive? Somewhere the program failed, isn't it? So how do we work among adolescents? That's a big challenge. And let's hear Dr. Ghosh.
Thank you, sir. So, good afternoon. So, I would be talking about our experience with adolescent-friendly health center. I think many of us has, already gone through that path of adolescence. So, 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 um, I when I go to the field with the caregivers, with parent, I play this game then and now. Although today we don't have time, otherwise I would have played. So I take them to their life when they were adolescent. Who were their favorite person? What where they used to talk about. Everything has changed in our life. So I also remember in my old days, if I have to even go out of home, I have to take permission. If I have to meet a friend, I have to tell why I am meeting this friend. If a trunkle comes, my mother will be standing there. Okay, whom this guy is speaking to. But now everything is changed, right? I remember my niece going to a doctor, and the prescription, it was folded. It was shown to the chemist with the folded, not showing who is this person, what is the diagnosis, and she was suffering from menstrual problems. So that was the kind of taboo where I have experienced in my family, and my family is a conservative, large family in Indian setting. But now everything is changed. I think internet, education, and we parents also have realized that it is time to change. So, but for our adolescents who are living with HIV, I think they need more time. We need to support them. So this is a case story. One of our case manager, Ria, is with us. She has created this story for a adolescent living with HIV. And I will not play this story, but highlight the important messages. So this is about a child whose mother got diagnosed with positive, and unfortunately she is no more with us. Then our CCF, got tested. The brothers and sister, she also got positive. But as you know, in our Indian setting, even I have experienced this. So if I am negative and my younger siblings are positive, then if the CCF goes home, then they will say, don't come this time. The elder guy is there. If you discuss about HIV, they will know the status of the sibling. So this kind of situation is still persist in our, community. So this is where, our AFSC services are introduced to this child. So she attends Sunday classes, and where she finds that, there are a lot of children like her are coming to the Sunday classes. They are, learning Thangta, martial art in Manipur. They are learning, how to play music instrument. They are opening up and sharing, what challenges they are facing in their family, in their neighborhood, while they visit the ART center, even those who are staying hostel, what challenges they are facing. So this really helps us also to plan our services, because unless we know, we cannot deliver services. So that is why I recommend we should read a book which talks about how to talk to a child so that they listen and talk you. Sometimes, we think we know the best, and, and we know how to guide a child, but we do not allow the children to open up and share their stories with us so that we can guide and help them. So why we need adolescent-friendly health services? We started our OBC work with CLHIV. We found that a lot of our children are, adolescent. They are living with HIV, in the rate of 10 to 17 years. The LFU rates are also comparatively higher in this age group. Because what we found, once I cross 15 years, I am asked to go to adult regimen. I have to go and stand in a queue where, all the elderly persons are standing in the ART center. I feel very shy. Okay, somebody will ask, okay, why you have come? You have come for your medicine or your parents' medicine? So I would avoid to go to the ART center. And even if I go to the ART center, if I am not taking medicine, my parents will get the scolding. You are not taking care, but I am not focused. I feel, okay, the problem is with me, but nobody is talking to me. They are talking to my parent, my mother, my father, my uncle. They are not talking to me. They are not, understanding who am I, why I am missing my medicine. So we looked at, there are challenges in terms of, SRH services. We all know that adolescent female who are taking ART have also pubertal delays. They have challenges with their menstruations. So unless we prepare our adolescent females saying that, okay, you will be now going to adult regimen, and these are the changes you will have. So how you will cope up with the changes? And, if you need help, who you will speak to and how we will help you. Similarly, mental health, we talk about a lot about disclosure. So, I am taking medicine. My father has said that, okay, this is vitamin you take every night. It is very good for health. Suddenly, I got to know that I am HIV positive. Now I am in a post-disclosure stress. I do not know, okay, whether I will have a boyfriend, whether I will have a girlfriend, whether I can marry, whether I can have children, what I have to do. I do not know. There are children who need dysphoria related counseling. If they are, they are not in male or female, they think I am a trans woman. I am an adolescent with HIV. So where I can get dysphoria related counseling? I am not getting enough sleep because it's a side effect of my medicine. I have mood changes. It is a side effect of my medicine. So if we will not prepare them, especially the adolescent, and provide them mental health services, there are challenges. So these are some of the possible reasons that I highlighted. So we follow all the global and Indian guidelines around, providing AL-HIV services. So say they talk about, delivering comprehensive services that is beyond HIV. This should be peer-led and confidential. When I am talking about confidential, there are a lot of questions from the provider side. Should I tell the parent that, okay, your child, needs certain care, but how we deliver this message to the parent is very important. So that means, yes, we need a confidential service. That means we have to take the consent of the child also. That whether, whom should I talk about your HIV status? Whom should I talk that you are missing medicine? Whom should I talk that you have side effect? So I think consent taking from the adolescent is key, that we learned in our adolescent friendly health clinics. And then we need to look at health system approach. Our ART center cannot provide all services. We cannot say that, okay, you bring the gynec person here, you bring the RKSK team here. We cannot do that. So that means we have to develop a robust mechanism of linkage, referrals. So that also we have done. So we have started 2 AFSC clinics in NHM urban PSC, one in Aizawl and one in Dimapur. So, everything is there. If we train the team about adolescent living with HIV services, we can deliver them. Then addressing disclosure and stigma. I'd like to tell one story. So one of the child recently, he has to run away from the hostel because the hostel manager and the children got to know that the child is taking ART. So we again, got him admission thanks to Dr. Joming, our state manager in Mizoram, who helped him to take admission and continue his studies because his exams are coming close. So these are the challenges we also face in the field. Then screening of adolescent risk behavior. If I am positive, my peer group, they are not aware of my HIV status, but we all have certain high risk practices. But our program focuses on me and not reaching the my peer groups, like the social network model Dr. Sunil presented. If we do not reach to the peers, we do not help them to understand why they are at risk. So now in ROP 22, we are looking at starting adolescent at risk intervention through our ALHIV as an entry point. Then there are other vulnerable children, like the street children, children who are in difficult settings, care homes, how we can work with those, train those care, providers, so that if certain risk screening can be done at their level and they can be linked to the OBC program. The last important is safeguarding child rights. So it's the responsibility of the parent and caregivers. It's not the responsibility of the agencies. Agencies can provide support. So that is what we focus in our caregivers training, in our caregivers literacy. We say, you go back to your adolescent days. You are restricted to go outside. You are not actually restricted to read certain books, right? I still remember I took a library, Lawrence's book, and I used to read in the night. And my father got to see this. He said, you have to return this book. And he told the librarian, don't issue such books to my boy. So, but now it's open. So how we will build that culture of right with our parents so that they safeguard the child rights as well as they help the children from being exploited and facing violence. So these are, different services already available in government setting. There are different ministries. And I really appreciate all these, services are designed to help the adolescent. But our adolescent living with HIV, they are very, lonely. Even their parents do not allow to take them to a relative's home because they think if I carry the medicine and they continue to take the medicine in relative's home, somebody will ask what medicine this child is taking. If the child gets sick there, somebody will say why your child is getting sick always. So they are really lonely. So getting access to these services, they need a lot of help. So what we are doing, we are preparing a directory of services, making available with our adolescent friendly clinics and also with our CCFs, the child care facilitator in the field. And we are doing a screening, looking at whether some of these services, they are eligible. And then we are linking with them. And thanks to our CCFs and state managers to helping this. So this is our framework where we focus, 395. We have currently 2 standalone AFSCs, one in Guntur, one in Imphal. We have hospital integrated or ARTCT integrated in Pune and Thane. With NHM, we have in Aizawl and Dimapur, and CBO integrated in Hyderabad. So there is a women CBO called Cheutha, where we work with them. These are the services like I already discussed. I would like to add 2 more things. One is access to vocational training. A lot of our ALHIV, I think you all know, they drop out from school either during 10th class or during college, because they think that I will be identified. My status will be revealed and nobody will give me job. And especially they also see stories in YouTube, in Google, that somebody has been, laid off because of his HIV status in private sector. So all these have really moved them into a insecure position in terms of, livelihood, securing their livelihood. So where we focus on providing, linking them to vocational training so that they can get self-employed. Similarly, education-related donor support. This is very important because a lot of our parents, I will present in my OBC presentation. A lot of parents do not have substantial, livelihood. A lot of them are women. Their husband passed away at a very younger age. They are young widows. They have to take care of the child, bring them up. So education-related support is a very key thing. And we also know that resources with government are also limited. They have to cater to other vulnerable groups who also requires education. So this is our delivery model. So we run a drop-in center in all our AFSCs. We have an outreach team with childcare facilitator. The children can walk in, and also we have social media, WhatsApp groups, and other ways of reaching to adolescent and bring them to our clinics. And I have already talked about different services that we provide. So this is one of our first AFSC in Imphal. We started in January 2021. If you can see that, I'm sorry, maybe the numbers are not visible, but if you look at the viral load suppression, when we started in January, it was 88%. And at this stage, we are at 97%. Thanks to Manipur SACS, Manipur team led by Sana. And so they really helped us to, get this done. And also in our AFSC, we run a FICTC so that, those who require HIV testing,
Please wrap.
30 seconds.
Yeah.
Yeah. So they can take the test in the FICTC with proper pre-test and post-test counseling. We also run a car for the second line ART, and thanks to Manipur team for supporting all this. So these are some of the pictures from our AFSCs. So these are some of the results that I have already discussed. This is my last slide where I would talk about that if we have to, like Sir has already emphasized on making it cost light. So we are already demonstrating that UPSCs, because the adolescent concentration is also there in urban areas.
Subhash, you have more slides, or we can take
No,
them?
this is the last. Yeah. So we can look at such UPSC models where we can, scale up our AL HIV services. We can actually look at the provider initiated HIV testing at screening. We have HIV testing guideline which recommends this, but can we make it adolescent friendly? Then last is about the helpline and counseling services need to be adolescent sensitive, because sometimes, they are asked, okay, go and get your pregnancy test done. How many boyfriends you have? So let us, bring them.
We will
at
have a round of
adolescent
discussion, so many
Yeah,
of these points
thank you.
perhaps can be raised here.
Thank you.
Thank you, Subhash, and sorry for cutting you short. Now, for the next speaker is Manish on Tal Club. Comments will at the end. Kindly note down all your comments, and we'll have discussions at the end. Only thing I will say that this is a very niche area in which they're working, and we need to perhaps bring more, educate ourselves more in this area. You start, Manish. I had one point to make, but since Subhash has eaten into my time, we'll go straight to you. Make sure that you give a bonus of 5 minutes to me.
Sure, sir, I'll try. Good afternoon, everyone. Respected chair, co-chair, and dignitaries on the dais of the dais. So I'll be quickly sharing the experience of Tal Plus on behalf of NMP Plus and Manoj. So most of us have heard about, like, whoever has worked for HIV knows Tal in some or the other way. So I'll be showing what is the model and what value addition or what we have learned as Accelerate from Tal and what value addition we have done. And we'll try to be as quick as possible, sir. So a little bit of history. So NMP Plus conceptualized a community pharmacy, right? In way back in early 2000, when the access to ART was not that wide, which we have today, fortunately. In 2004, though, our free treatment was available at around 8 centers, but again, it was limited. In 2000, and the NMP was kind of trying to see for alternate methods, alternate models, as Sunil in the morning session said, right? There was a public sector and there was a private sector, which was kind of costly, and somewhere in between subsidized kind of thing was looked upon. And in 2006, with support from MCure at that time, the first community pharmacy, TAL, was established, and the aim was the accessible and affordable peer-led pharmacy in the private sector. And the focus was around pharmacy at that time with add-on services. So the model was at that time, and which continued till recent time. So any person who for any reason does not want to go to a government facility and prefers to go to a private facility for ART, so he or she can go to a private physician, get his or her consultation or the prescription, and the medicine can be procured from Tal Pharmacy. What value addition Tal Pharmacy did was the pharmacist and peer counselor. So as sir rightly mentioned, you need to have certain minimum requirements if you want to have a pharmacy, at least a pharmacist. Plus, we know private sector may or may not have a counselor cadre like we have at ART centers. So they complemented that. So private sector provided clinical services, while the social services was and the medicines was provided by Tal at that time. And Tal Pharmacy had all the regular required licenses, had 3 outlets in Pune, Ahmednagar, and Nagpur. And most of the important thing, the drugs were subsidized, right? So it was an in-between model, not a completely free, but not as costly as the private sector as well. So Tal Plus I'll talk about. So in 2020, when Accelerate started working in the geographies, we collaborated with NMP Plus, and the aim was to transform a already working pharmacy into a integrated health center, and most importantly, self-sustainable. So it should not be depending on because it's a kind of private sector, not depending on some other partners or some government for say HR or drugs. And most importantly, by the community, for the community. That's how mainstreaming, stigma reduction, discrimination reduction. So this was the changes that were prepared when we added on the Tal structure. There was a refurbished infrastructure. So infrastructure was already available with NMP Plus. So there was no additional requirement of space or anything. We just refurbished the area, make it more clinic-like thing. Some staff were added. So pharmacist and counselor they were having. In addition, doctor, outreach worker, and staff nurse was added. It already had some testings which was broadened up, and basically a mechanism for linkages and referrals was established. Services that as of now Tal Plus provides is a comprehensive health service. So ART definitely remains the mainstay, but then treatment for minor opportunistic infections, specifically non-communicable disease. I'll be talking like about how many are the numbers. General health, COVID-19 vaccination, where they added. In addition to this, pre and post exposure prophylaxis is available. Telemedicine with home delivery is also available in this center for the patients who are availing care from there, and definitely counseling and the peer supports. This is flow. I am not going to get into detail, but the flow is if client has a prescription from a private doctor, they can come visit and directly meet the counselor and pharmacist. If the client wants the complete consultation as well as medicine, then the flow is very much similar to what we provide at ART center, right? From going from counselor, doctor, lab technician, staff nurse, and then pharmacist. This is care continuum. Approximately, as of now, approximately 600 patients are availing ART from there, and it's not government ART. It's a self-purchase. These are clients outside of our what we are getting from ART centers. Viral load is being available, and we can see the blue bar is viral load done and red bar is viral suppression. Almost 95% suppression is being seen among the patients. So, sir, if you recall, and under guidance of Goel, sir, we developed this format for private sector reporting way back in, I think, 2018 somewhere. So this format, quarterly basis, Tal is being sharing with SACS to be merged into the overall reporting system of the government. So HIV related, in addition to those 600 patients, there are 51 PLHIVs who have been linked to government ART centers, right? So this is also an important thing. This makes a bridge, right? So private sector patients may not be, initially they had some inhibition, but later on wants to go to public sector, right? So it makes a bridge referral between them. There are, as of now, currently when we speak, there are 30 PLHIVs who's been screened and diagnosed of having hypertension and diabetes and are taking medicine from Tal Plus. There are 34 clients on PrEP and 40 clients availed PrEP during this, PEP mostly non-occupational, because what we provide at ART centers is limited to occupational. So non-occupational is available in TAL. Non-HIV related, I'll focus on this. There has been, because it's a clinic, we are promoting it. There are 69 OPD based healthcare. So this is kind of mainstreaming when HIV negative is also walking in the same clinic and asking for services. There are 16 clients, non-PLHIV, who are taking medicines for hypertension or diabetes as a chronic care. There are 14 clients availing hepatitis B and C. And most importantly, with much efforts of Manoj, it was a COVID-19 vaccination center as well, where 993 PLHIVs, 487 HIV negative, mostly family of these are direct walk-ins as well, and 750 key populations also avail the services. And there are diagnostic as well, like almost we are seeing 7% of positivity rate, also 359 tests has been done. So what are the value addition and the lesson learned in these 2 years? So one thing is infrastructure was already available. We just refurbish it and make it more organized. It's not going anywhere. It's being sustainable. One of the most important thing was data cleaning. So so TAL was working as a pharmacy. Their complete data was the sales record. And what we, based on our experience of working in program, we know how to monitor a client longitudinally, right from the diagnosis till the retention and viral load suppression. So that is the part that we value added. And again, now it is in the system and not going anywhere. System strengthening and skill building. So from a pharmacy to a more counseling based, more tracking based activity has been done. Comprehensive health approach. Now, as I mentioned, NCD are being incorporated, other health elements are incorporated. Definitely it's there, it's small in number, but it's definitely showed us a way that where we can take this to make it a more sustainable and comprehensive. And finally, the HR. So every time HR comes, yes, we have added some HR. As of now, the revenue are sufficient to kind of sustain approximately 40% of the total HR cost. And that is the next step that we want to work, that once the project support ends, and this is what Sunil was also mentioning, we are aiming that in next 1 year, we generate the demand and make TAL a completely self-sufficient clinic itself, which acts as a bridge between private and public sector. There has been, so we are working on demand generation activities, as well as I mentioned, making TAL Plus self-sustainable, comprehensive clinic. There was a recent NACO visit as well. In addition to this, the pharmacy has worked closely with NACP recently. There has been some local procurements specifically for the regimens like TLE or TL, the formulations which are phased out from the national program. So pharmacy is providing quality products at NACO rate. So at the last purchase price, they're actually able to provide SACS, and almost 7 SACS has procured medicines from them recently. This is some history where they have not just worked on provision of care, but also reducing stigma, reducing discrimination, mainstreaming. So you can see celebrities coming there for cause and promoting TAL Plus, promoting positive living, promoting PLHIV care. So these were my slides. Thank you very much.
Very much, Manish. You've kept your tryst with destiny and finished in in the time stipulated. Now, what the sequence will be that first I'll ask my co-panelists to speak, and then we'll throw open a discussion with the people present here. 2 points I would like to make, and then I'll give the point to my co-chair. One was about the adolescent health. A whole lot of things were happening then, and Dr. Subhash, they're still happening now, that children do not share things with their parents. Sometimes they share with the siblings, but not with the parents. So parents brought up in or keep in their own the way they were brought up. The parents were brought up, like about 30 years ago. So they would not think that this is happening. And sometimes, even when they know or they guess, they would not like to speak or intervene. Mothers perhaps are more, uh, you know, involved as compared to fathers in our society. That's generally anywhere, north, south, northeast, wherever, So these are the things we need to, particularly when it comes to the health, we need to take care how we do that. Yes, and very, kind of specific points you made about traveling with a child who's HIV positive. How do we do that? Those are things we'll further open that discussion. About the pharmacy, it's a good model. It has stood the test of time over the years. We have improved it. But the challenge now more than ever before is because the numbers are now big. You have in the program, you have 1.5 million people taking drugs. So when the numbers are more, you tend to lose sight of smaller numbers in the program when the numbers are more. So it is important that we need to be careful about the viral load and their regular uh, monitoring. That's very important because हमारी बीमारी में सिर्फ दवाई लेना ही काफी नहीं है. You have to do three things simultaneously. Adherence, which can be reflected by viral load suppression. Then other comorbidities, and third is general monitoring of the PLHIV's health or other parameters. All these, because if he's not if the patient or the PLHIV is not visiting any other facility, then pharmacy itself becomes, or an area surrounding it has to become a support giving center, which we can again learn from what is done in the transgender clinics, because part of it is part of a healthcare setting, and the support groups are at times not in the hospital, but outside of it, maybe across the street, like that CDC center that we saw in Imphal, Jennings. So that is something that we need to do. These models are available, and we need to constantly learn from each other. It's not that Simran or in the CDC they're doing for transgender health or wo ek silo hai. No, we need to learn from each other. So this is what my comments were. Now, Dr. Vidal.
It's a privilege and honor to be speaking before ASND, sir. And usually within NACO also during meetings, I think twice before speaking anything in front of him. I have to really think what I should speak in front of him. So, now coming to the point, working as a program manager in a government funded program. For me, I have to look at the new initiatives and the new models developed by the donor agencies, by the multi-vector agencies. That what ASR always says is that it should be replicable, scalable, and economical for those initiatives and inventions to be adopted into the government program. That's the matter. Thank you.
So thank you, sir. See, I didn't have particular statement to start with, but one of the things which we did in the last 3 months or so in AP was to try out new stuff. I think with the help of the partners and something we tried to do new stuff. One is that we launched a prepare, the prep awareness and reach out, which was itself launched by the health minister herself, bringing the main focus of HIV/AIDS control into the backstream. I think Andhra was always a leader in HIV control and all, but we wanted to bring it back because I think the chief secretary himself took upon this task that HIV, because I think they were reviewing one of these days the SDG targets, and then we suddenly popped up that somewhere the Andhra's effect or the action was not up to the mark. So that's when there was a stress that we should be back in track, right? So that's when we started this initiatives. The other initiative which is relevant to this point is called Safe Life Initiative. We launched it in with the help of the local university there, which talks about 4 streams. In fact, we also discussed with the Women and Child Department in the state government. So we wanted to brand it into a topic that it has comprehensive. I think that's the word which we are looking for, right? Comprehensive. Diet and nutrition, it's a part of our Safe Life campaign. Fitness and yoga, I think we have put it as one. We also talk about NCD care. We work on the comprehensive cancer care. So we also talk about NCD care because Andhra is also one of those states where the disease burden is moving towards the NCD. 65% of your disease burden is towards the NCD. So we wanted the young adolescent. We also made a critical component as HIV/AIDS also, the awareness. You talk to doctors. All of this had come to me when we talk to people, right? So in fact, we called our ART doctors and asked them, how do you go about a PrEP regime? They have only studied about it when they did MBBS. So that's the gap which you are looking at, right? So when you're talking about, in fact, we have started this talking to the people on the ground, right? So we started talking to, in fact, I publish our AP SACS publishes a newsletter every month. And I was told that this newsletter reaches everyone, right? So I asked ART doctor one day, have you read our newsletter? So he tells me, I have not got it. So I think there's a lot of silos within our own organization. When I met Nidhi ma'am, that's the first thing she told me. Naveen, you go and see your ICTC center and your ART. You can actually track your LFU before they become LFU. So in fact, I think, that the lessons which I've learned so far in the last 3 months is even our partners are not talking to each other. So that's the lesson. Leave aside. And if you come to a SACS office, the nested table won't talk to each other. So I think that's the things which we are trying to do, bring the synergies. There's an excellent thing which we have learned in the NACO leadership. What we have learned, I keep telling this to other counterparts. If you talk about 6 years of healthcare, NACO actually does it. The awareness, the acceptance, all the 3 parts, the availability, affordability, and accessibility. And the last one is the adherence. So if you see all 6 A's of healthcare, which is very, very important for any NCD care or any governmental thing, NACO has been doing it. So in fact, I was discussing this in the morning. There are lessons which we have, which could be helpful for the other parts of the health management also. So which we should learn. So when you talk about comprehensive healthcare, we also look at not just like sir was talking about comorbidities. When anybody comes to my one-stop center, they would be screened for cancer. In fact, we are starting our cancer screening for HRGs and HIV patients very soon. And all the OBCs, the oral, breast and the cervix would be taken care of. We are also trying new things which are in the field. Like for example, thermal coagulation is one of the techniques which can be used for cervical cancer. So which could be used here, right? So that is one more thing. And we are also looking at developing a palliative care. When we talk about comprehensive palliative care, I think 6% of the AIDS patients would need palliative care. So that is something which we are looking at. And the part is, I think, the reason why NGO, why would government fail and where the NGOs would come in is to bring that last mile connectivity, bringing that space around I think Aditya was mentioning it, that the person is taken care of. I think that is where the NGOs would come in a big way. Not just what if the breadwinner becomes sick, right? So what would happen to his family? So these are the questions we should look at. And coming from AP, that's one lesson which we have learned. What we do is dashboard management. I think that's one of the states which is highly driven on data. I think it also says that no one is left behind, right? I think that's the agenda when we talk of any scheme. We track that last person. In fact, I was running a pension scheme. When the pensions are distributed, they track the last person, whether that person has got the pension or not. So that's something which AP has a tradition as it, the comprehensive care. I think comprehensive care in everything. So I think these are the lessons which we would learn. I'm also learning. I'm just 3 months into what I'm doing. So we are also learning. But what sir was very rightfully in his opening remarks, these symposiums, in fact, I'm calling off a lot of knowledge accumulation has happened over a period of time. Either we have forgotten or there is a need to relearn them or unlearn them also. It's very important that we unlearn them also. I keep telling them, if you put the same team, you'll get the same results. So we had to mix match the teams to get a different result, right? So we are trying some of the management techniques within our organizations to rebuild and bring back AP on track very soon. Thank you so much for my introduction. Thank you.
Thanks, Naveen. So two things come out of majorly, lots of things we talked about. One is for the partners that how we need to work. And that's actually, we have a Vinita's division here where the work is housed of partner management that the work need to be aligned, whatever other projects that they're doing, they need to be aligned with the national programs priorities, and they should be housed properly in the state SACS with a strategic leadership in control. That's important. And to the states, I would say that our mantra for such things are such collaborations are cooperative work is that it has to be investment like, because only then you can replicate. Simply because they are bringing some dollars, it doesn't mean that I can give you dollars. So whatever they do, it's got to be investment like and replicable. So good points made by him, and also we can learn a lot of things from the states they're doing. I always say that in this country, one size doesn't fit all. So what works in Andhra may work in UP, but with some tailoring, So both the states are used, So वो कैसे होगा UP में वो भी देखने का है. तो UP में मुश्किल नहीं है, because if they see somebody is leading them, they actually, people on the ground are looking for leaders. If they find a leader, they'll actually put more than anywhere else in the country. So now coming to Manipur, Hemjata, I request you to now.
Thank you so much, sir. Very good afternoon. And it's a privilege for me to be a part of this valuable, beautiful program with ASDG and all the DGGs and Director NACO with me. So taking this privilege, I just want to talk about the things that are happening in Manipur. That is, as you have been highlighted that Manipur has opened up an adolescent-friendly health clinic, first of its kind in the country in 2021 January. And as we all know that this age group, we face through many challenges and barriers, as we know that we are dealing with the child and the adolescent living with HIV, that they have specific challenges, not because of the adolescent itself, but even though we have ARV in hand, I want to say that it's not a magic drug for this specific age group, because they have specific, challenges, as it was shared in the presentation, that they have been prescribed a vitamin. They're saying that it's a vitamin for the ARVs, and once their status disclosure comes, it's a shock to them. And so it's very much in spite of all the challenges that they face, that Manipur, of course, under the leadership of NACO and the project Accelerate, that it's been privileged for the state that we could address the HIV treatment barriers among the AL HIV in achieving the viral load suppression. And we have developed certain specific comprehensive service delivery model, and also various models like the individual case management approach, then categorizing and prioritizing of those virally high this adolescents or the child, and treatment new, and even with the associated OI. And so we have, also tried to see the psychosocial and the socio-economic point of view of the kids, and also the mental health, mental issues that we have. We had developed a collaborative model with the NHM in order to address even the mental health challenges, and also other collaborative model with the anti-EP program also for the ITP MOPA, because to start with, there was only 29% of the LHIV that the ITP could be, covered up. But with the development of this model, that would now we can have reached up to 85% of the ITP, then even for the treatment with all these models, we could, bring up to 95%. It was in with the baseline cohort that we have, it was only 70% of the viral load that they could suppress, but now it has reached 95%. So it's so I think this model that we have should be nationally scaled up, and with this short view, I would like to end my speech. Thank you.
Lata, now I would request Apsara ji to first introduce herself and then, okay, wow.
So I think when Apsara was here, she comes from Chennai. Okay, she's the most popular person in Chennai. So in fact, she's a celebrity status in Chennai. So we have a common friends together. So when I came here, so I introduced myself as I'm Vikram Reddy's friend. So we have seen and it's also very important, a person of that stature coming publicly and putting it, you know, across the people. I think they come from a very affluent family too, right? So that's very important. It itself is a very strong message. I think we are about to learn from them. One more thing, what we did in AP SACS officer, AP SACS office also has a transgender washroom. So I think, in fact, when we ask them to do it, so I think that's probably the first. When we talk about, we should also put up our thing first, right? So if I talk about transgender, then they'll ask that there's no washroom for transgender in our own office. So I think that's the first thing we did when we renovated our, AP SACS office.
Thank you so much for a wonderful introduction. I'm Apsara. I come from Chennai. I'm a editor of a newspaper, and I also represent a political party as a national spokesperson. I am not an expert on HIV and healthcare, but I think a few observations I've made and learned today, which I want to share with you briefly. I think it's very important when you talk about comprehensive service delivery to understand emerging behaviors within the community, whether it's physical behaviors or gaming-driven addictions, behaviors, patterns. A lot of people preferring alternative, ineffective therapies being peddled over tried and tested medicine. And also a lot of kids have come into contact with that we work with as social activists who look at the trans community as a vulnerable soft target to take out the depression and frustration and physical violence. And through that peddling of a lot of sexually transmitted disease. I think that's very important to understand tech when you devise comprehensive solutions for HIV. I think access to testing and counseling is very limited, especially the state that I come from, whether we're in government or not, with the political party I represent, even for the last 10 years. I think the district level accountability is very, very low. I think there are hardly any facilitators and doctors and people in districts who are, there's a state policy, there's a national policy that helps us and funding that comes, but I don't think there's district level micromanagement or accountability. I think chronic care specialists and specialty wards are missing for HIV in Tamil Nadu. I think we don't have people who deal with chronic cases or specialty wards. I think it's also important to have specialized centers, which can be either residential or daycare centers for people who are battling a chronic virus. I think standalone centers and safe spaces are essential. I don't think people want to go to hospitals. I think it'll be nice to have centers which are inspirational, which also tackle allied issues of depression and sleep patterns being altered and all those kind of anxiety and anger and frustration. I think it's important to have centers of inspiration. I think Mithra will be a great example going forward. And I would make a humble suggestion to add in therapies like, art therapy, color therapy, green therapy, gardening, because I think these can actually bring in a great quality to the service you provide. I also noticed, I think this is taking it away from my community, but HIV medicines for HIV positive pregnant women aren't supplied properly. I think most of them don't have access to medicine, especially in rural areas. And I think it can help the child who's going to be born. There's also limited educational programming on trans health generally, and especially when it comes to HIV. So the role of hormones, the surgery, the allied medicines that they have in terms of, it could be cosmetic, it could be, more internal medicine. But I think it's very important to understand, to have programming, educational programming geared towards trans health. Online and offline tech savvy outreach, I think that's missing. I think there are lots of government programs devised at the center and state, but in terms of emerging new eyeballs, in terms of HIV prevention, in terms of kids contracting it or adolescents, I think we need to get more tech savvy and be on, like, whether it's Reels, whether it's YouTube. I think it is a medium that we need to explore. I think NGOs and governments must get more tech savvy, must get more gadgetized in that sense. I think unstable housing is something which is not handled effectively by governments, or I don't know about other states. But I think there's a lot of unstable housing which happens with the trans community, and there's no proper mentorship or tracking. That's very important. I think geographically, if there are any parameters that can be drawn where, there's a person assigned for, every cluster of trans women and they can track them wherever they go, I think it's very important. Um, I think a policy which is a person focused, not community focused, is also very important because every trans individual is different. They all don't react the same way to the virus, so they don't react the same way to the medicine, or they don't react the same way to the help that's offered. Some people can be very defensive and offensive. I think a person focus is extremely important, which means you need to have more hands on the table. Social network and social media I've already spoken about, and I think I want to make an observation about what Simran had said earlier about I don't want to. It's not an attack against escorting, but I think we also have to have our clear-cut goals. Am I correct? I think I don't want to attack escorting, but I think clear-cut goals to reduce the infection is essential. I think the governments have a huge role to play in this because when trans individuals are ostracized, we have no access to housing. There's no reservation in housing. There's no reservation or subsidies in terms of medicine, in terms of transitional help, and also opportunities to work. So to tackle hunger with the limited access to opportunity, I think the only thing that's left is danda. So I think clinics like Mitra can also turn into, collaborate and do job fairs. I think it's very important because that will help a great deal in terms of even spoken English classes, even vocational training, running job fairs in collaboration with police departments and governments. Because I think when you empower them, I think they move away a little further away from the disease. And finally, I think with trans children, I think we need to have a helpline. There are a lot of kids that I meet who are 8, 9, 10, especially on Instagram. I get message from 14-year-old kids and 11-year-old kids saying, I want to become a girl. It's not easy. I think you need proper advice in terms of hormones, in terms of surgery. A lot of them are going to quacks and getting operated. They're, I think that is something which I think the HIV policy has to address because they are a very vulnerable cluster. And thank you so much for the opportunity. I'm here because of Sunil and Simran. And thank you so much to all the stakeholders because it's my first HIV symposium. I just hope I haven't sounded like an amateur.
That was very good, Apsara, and we'll continue to invite you. And NACO, as we say, is a university. So you're today enrolled as a student of NACO University, and one day eventually, inshallah, you'll graduate as well. So one thing I would like to tell you about the program, the NACP. From the very beginning, we do not bold, underline, sit in judgment over people's choices in life. We are just facilitators and primarily healthcare providers. So that's what this program does, but embracing everyone along and not passing judgment over how they are, their choices in life, whether it's their profession, vocation, or what they want to be. So that's we with a lot of pride we say. And one example is the person sitting next to you, though she comes in a different avatar every time, and it took me some time to me pehchanne mein. Chalo, now you say something.
Thank you, sir. First of all, thank you all the NACO officials, USAID officials here, Accelerate program, the fantastic team who has put up this symposium. It is really a lot of learning for people who are also implementers and who are working very, very closely with Ministry of Health to make a better health for transgender people. Having said that, I just want to start my conversations with specifically some of the things that people have been talking about. So spoke about breaking silos, and I think sir has also tailored on Sampurna Suraksha, which is a very strong front foot on talking about a comprehensive health. Health should not be seen in silos. Health should be seen as a human right. And that is where we are heading towards right now. And it is a very, very important aspect. Having said that, couple of things we've been talking about it, and Simran and Subhaji and Manish sir, all of them talked about it very eloquently. And I just want to highlight that, sometime back when I went to sir talking about the transgender health and establishing, health desks within the hospitals, sir changed one word in the entire concept note, which was specifically from social welfare to social well-being. Very strong change, no? But if you really think about it, you will realize what it means. There's a big change, and it just struck me, and my entire concept of how you look into the transgender health really transform within that. And thank you, sir, for guiding us on that. Having said that, I just want to talk about a couple of things that we really want to understand. One is where Dr. Sunil sir talking about the prevention, treatment, access, and other things. And I have another circle to that, add to something like that. One is that when we talk about access to health for transgender people or any key population, some of the things that are very important for us to understand. One is that we really want to work around access, then we experience, then we actually retain on services, and then we advocate. These are the four things that we really go through, right? When we talk about accessing health. But the important part about that, when we talk about the key population, is that where does the health lie? We are all health professionals. How frequently we go to the doctors? We don't. Like we try to self-medicate ourselves, and Vishali is smiling at me because this is an age-old conversation that we are having from the time of Humsafar Trust. It's only when I realize that it is important for me. It is only when I realize that as a community member, I should be aware about my health, and it has a direct connection towards mental health, social support, all these important aspects which the Mitra Clinic and other initiatives that even Subhash sir talked about, the adolescents, they are ticking on it, right? They're ticking on this all additional things where how do we bring communities support? How do we bring communities to really understand this is important for me? I need to access. The second thing I want to dwell upon is that all these clinics, they are talked about health impact indicators, but what we need to understand that there are social impact indicators also they are achieving. Mitra clinics and all these things which we have not realized enough. I just want to dwell on that. Like for example, in Hyderabad, Rachna is here, and for longest time in Hyderabad, we were really struggling to talk about transgender welfare and transgender rights. And she managed to establish the Transgender Welfare Board, which was a very important thing because Hyderabad is an epitome of Hijra community. It's a very volatile situations where Hijra's gurus come together. And so this is a very social impact product that has come out of the Mitra Clinic, which we have to acknowledge very, very strongly. So I'm just saying is that, that is something also we need to work around with that. The other thing that I just want to talk about is that we are expanding on TI, we are expanding, and sir was also talking about how does the comprehensive health complement to the national program, which is a very, very important aspect. I think the initiatives that Accelerate has done has taught the national program that we have to go from away from our comfort zone. There are some financial services like you see TI implementation, the design itself for 1, 2, 3, 4, 5 now we are into. We realize that we can't design a custom-made program for all the key population, right? We have to have a universal program, but within universal program, we have to find an opportunity to find out services which are non-financial, and that is essential for the communities. And I think clinics and other initiatives of Accelerate does talk about that. It talks very eloquently that all the services may not require money. Support for a treatment literacy doesn't require money. You need to have a community champions who can do the treatment literacy within the communities. When you talk about family support, is something that we can be created. So it is a very, very important things. And it does talk about affordable health because you are working with the community for some amount of time to access health. Tomorrow, when they are already realizing on the health, they will go to the health practices and access the services over there, because we are also dealing with reducing the healthcare stigma when the health desks are created. When one health desk is created into the system, it is going to transform the entire health machinery to understand the dynamics of sex workers, transgenders, and other related aspects. The other thing that I want to talk about is that when we talk about the key communities also, like for example, if I talk about MSM, when we talk about transgender, whether we talk about sex workers, we are not talking about everybody, everything fits for everybody. There are diversities into that also. And I think when the Mitra Clinic is also going to address the issues of trans men, it is an important aspect that is not being dealt on SRHR. Here, I think Dr. Srijit is also there somewhere. From IPPF, and Sonal Gyani is also there. I think SRHR and HIV integration is the long discussions that we are talking about. And that is where, when we talk about breaking the silos and partners coming together is important. We have to now start talking about universal health, because we are touching upon the agenda of SDG, Sustainable Development Goals, where we are talking about good health, where we talk about non-discrimination. And also the last thing is that, Dr. David is here, and I think we are also talking about specifically from UNAIDS, and we are talking about nobody's left behind. When we talk about substantial health approach at the national level, we should make sure that if the general population is finding it ease to go and access the health, even the transgender person or PWID or sex worker or MSM or person living with HIV or young person should be able to find enough courage to go and say that this is my health problem and I need help, and affordable health, quality health, and health with dignity, which Simran is talking about, which is very important. I just want to finish with last line, which is very beautifully said in our culture. Sarve na sukhinas santu, sarve santu niramaya, sarve bhadrani pashyantu, and sarve na dukkha bhag bhavit, which means that is everybody has a right to health, which is beautifully said in our culture. And that we are not just doing something new, but what we are trying to continue is that what we have already initiated as part of our right, which is health as a right and not as a benefit. Thank you so much.
Last speaker is the person sitting on my Dr. Bit.
All the experts have spoken, sir. So I don't have much to add. But I think what we have heard today are three good models of comprehensive service delivery. I have the opportunity to visit some of these clinics. So some of the observations are, one, this is, as Abhina mentioned, it's not just fulfilling a health goal, but it's also a social impact goal that we should keep in mind. So when we are measuring the success of these clinics, how does that also get measured beyond just a health outcome is what we should be looking at. The other thing was how the adolescent health clinics, and I couldn't visit the one in Imphal, which I promised Roshan that I will visit next time. Is how do we mainstream it into the national health program? And if that model works, that will be a really self-sustaining model that can go forward into the future. Because what we need to start thinking of, as all speakers have said, is how do we mainstream a lot of these services within the government health services for making it more sustainable. On the Mitra Clinic, as well as with the Tal Clinic, FHI is also supporting them to be social enterprises, to generate funds on their own, to stand on their own feet. And hopefully that is also going to help in making it sustainable in the long term and not be dependent on donor funds. So that's another input that we'll continue to provide to all these clinics. One of the services that I would encourage Mitra clinics to also start looking at is legal service, either connecting with the Dalsas and the Salsas in the local areas, because of so much of, you hear so much of gender-based violence and other issues that come up, and property issues and other issues. So how do we deal with that when you're talking about a comprehensive package of services? That should also be included within the package. And one thing that I noticed, which you should be careful about, is that the HIV positivity, if you really look at your Mitra clinic, is not very high in terms of new cases detected. So are we really reaching the most marginalized of the transgender population? No, this is the initial stage. We are all in the learning stage. But I think we should also keep in mind that the other, whether we are reaching the really marginalized of all populations and bringing them to our clinic. So these were my basic thoughts that I wanted to. Thank you.
Thank you, Dr. Thank you, Dr. Mitra. Thanks, my panel and my co-chair. Now, I have instructions from PAS that we need to restrict the discussions and go for lunch. And The subsequent points can be taken up at the, maybe you can have a networking lunch or at the end while we are finishing. Okay. So, but a few questions. Someone who thinks that it's really bright, you'll be penalized if the question is not good. So tell me, raise your hand. Or should we straight away go? बिल्कुल बताओ 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 माइक है जल्दी से ये तो अच्छा क्वेश्चन होगा बहुत वाइज है ये No, it's not good. You can come.
For being here, and definitely Simran is a darling sister of mine. So you are doing wonderful job. This initiative is really, really very important for the comprehensive healthcare. Coming to that, so I have a one concern actually, and the thing is that while I was going through the presentation and all these things, one thing was coming in my mind because all of us know that gender affirming care is a multidisciplinary approach, and definitely mental health is an integral part. Most of the time we have seen that people decide on a sudden basis that I have to go for the gender affirming surgery. And after that, he or she repents, oh my God, I haven't assessed really very well. So that is the part I was just wondering to know actually from your team. Anyone can, tell me, I mean, how you assess that someone is really prepared for gender affirming care or any of it, like it can be HRT, it can be hair removal process, it can be the surgery. And one important thing I would like to advise you, and I think this is for all of us. Recently, I got the opportunity to visit GRS Montreal. That is a very good clinic for the transgender people. And the most important part, I like that they give post-operative care. So after the surgery, I mean, how you can ensure the person is getting, the post-operative care. So these are just my two observations, and thank you so much once again.
Thank you, Amrita. It's always a delight. She actually made a very valid point, and there are no answers to that, but we need to be mindful of what she has said. Doctor साहब, आपका नंबर बाद में आएगा. Yeah. आपको तो मैं रोज सुनता हूँ. नंबर आएगा बाद में आएगा.
Thank you, sir. Thank you all dignitaries. And sir, इससे पहले हम presentation देख रहे थे adolescent के ऊपर. Sir, sorry, sir. Sorry. Sir, मेरा नाम पूजा मिश्रा है और मैं इंडिया HIV AIDS Alliance में काम करती हूँ और मैं NCPI की तरफ से एज ए यूथ को रिप्रेजेंट करती हूँ. सर, अभी हमने एडोलसेंट के ऊपर प्रेजेंटेशन में देख रही थी. एडोलसेंट के ऊपर मेंटल हेल्थ और SRH में सबसे ज्यादा प्रॉब्लम होता है सर, और हमारे यूथ में तो उससे भी ज्यादा प्रॉब्लम है. और लेकिन सर, अगर मैं नेशनली बात करूं तो हमारे यूथ के लिए कोई प्लेटफॉर्म नहीं है जहां पे हम अपनी बातों को रख सके, जहां पे अपने मेंटल हेल्थ की बात कर सके, जहां पे SRH की बात कर सके, जहां पे अपनी कैपेसिटी बिल्डिंग की बात कर सके. तो सर, वी नीड अ प्लेटफॉर्म फ्रॉम योर साइड. एंड सेकंड सर, अभी CSS का चल रहा है कम्युनिटी सिस्टम. सर, उसमें हमें एज ए यूथ स्पेस चाहिए सर, कि अगर हम पीयर में ले रहे हैं तो यूथ को फर्स्ट प्रायोरिटी दी जाए. थैंक यू सर.
Thank you, sir. Dr. Anukumar Puri, DDG. Sir, actually, two people, I mean, Amrita as well as Pooja, they have raised a very valid point regarding the mental health, whether it is related to the youth, whether it is related to the transgender, and whether it is related to the, in general, youth. That is also equally important. They are also our vulnerable population. No doubt that they are not high risk, but they are at risk population. So we have to take care of them also. So mental health
needs to be addressed to. And as you know that not only it is in the youth or not only in the PLHIV or TG population, elsewhere also we always face some phase of life we are facing identity crisis. Everybody has faced the identity crisis. And what is the reason for that identity crisis? Who am I? Nobody knows that who am I. It's a very, actually, I'm a soul, and this body is, so, sir, ultimately, we have to, I mean, the answer to all this is meditation, and we have to go for the spirituality.
I will answer this question. So, ma'am, if you remember, in UP, what we did is all the doctors, MOs, we passed one small GO saying that they should do that digital learning NIMANS course. It's a course from NIMANS which offers you. And with that simple one GO, we were able to get at least 2,000 doctors have basic qualification in counseling, mental counseling. We are trying to replicate the same thing in AP also. What we are trying to do is there's a program which we are launching very soon, probably in January, which is called Emotional Assessment for Student Educators, where the adolescent students also will be taken care of. So we are also working on that, not just for the HIV and these people, and we're looking at adolescent as a whole. So we are working on it. I think we'll also put whatever material we create, we'll also put it on the CME courses.
Thank you, Naveen. In the end, 1 minute. Vivek, मैं तुम्हें बुला रहा था यहाँ पे, तुम यहाँ आ जाओ. You come here and just take 1 minute. 1 minute, Vivek and I, and then you don't. अपने ideas मत लेना Vivek मैं क्या बोल रहा हूँ. Don't get ideas. Okay. So Vivek and I we have a quiz at the end, right? Then we'll break for lunch. Please introduce yourself. You wanted to speak? Yeah, just give him mic for a minute. Yeah.
Yeah, my name is Alok. I belong to the drug user community. I just want to say this, I don't see any platform, this young lady said, for drug user women or drug youth like na, or a PWID or FIDU. I mean, I don't see any platform. I mean, they are vulnerable. It's a high prevalence of HIV amongst them. And I don't see any platform for them. That's what I wanted to say, sir. Thank you.
Now, actually we hear him, and it can be perhaps somebody can talk to him and we can take that point discussion further with you. We'll end this pre-lunch session by a quiz. There'll just be one question. आप आइए इधर विवेक, क्योंकि आप वो जवाब दे सकते हो तो आपको मैं पहले इधर बिठा रहा हूँ. Okay. Now, in the pre-internet age, what was the medium through which MSM word तब आया भी नहीं था शायद, gay guys would find each other apart from cruising? क्या तरीका होता था? ये तुम्हें नहीं बताना है, तुम्हें तो पता ही है.
अच्छा, मुझे क्या मुझसे पूछ रहे हो? मैं
So you see, this is that what Subhash said then and now. It's that question. Okay, what were people? See, it's very easy now to have an app and to have a dating platform for MSM, all kinds. So what were people doing, young people doing before that? There's a point that I'm trying to drive at. Somebody will raise their hand. Rajesh, तुझे पता है? Yeah. Tell me who's that. Introduce yourself. आगे आ जाओ भाग के.
मुझे लगता है सर कोई आंखों में इकरार होता था. I am a bisexual woman and I think that continues to be the reality for communities which are still in the closet. But yes, of course, outside of that.
होता होगा तब unfortunately metro भी नहीं थी. So actually many of you who have been working with me for last 5 years know that my cadre is postal. So as a very young officer, maybe about 30 years ago, I went visited a post office and I found a young boy fighting with one of our assistant postmaster who was in charge for the big GPO, in charge of the post boxes. So the drill in the postal department is that if you apply for a now of course all those things are gone, but if one applied for a post box, inquiry would go home. तुझे पता है ना,
Yeah.
उस दिन discuss कर रहे थे.
बॉम्बे दोस्त.
So वो जाके discuss करते थे उसके घर में. So this boy came and was fighting with the postmaster. Why did you send somebody home? And my parents have got to know that I am hiring a post box. And why was he hiring this post box? He will tell you.
Yeah. So in 1990, India launched its first LGBTQ plus magazine. It's called Bombay Dost.
Bombay Dost.
And in Bombay Dost, we had this wonderful column, जिसे कहते थे खुशखत. So मैं भी उसी खुशखत का आउटकम हूँ. मुझे पता नहीं था मैं हम सफर में बैठ जाऊंगा आकर. But it was very interesting that you know, you could pay a very small amount और आप अपने आप को advertise कर सकते थे बॉम्बे दोस्त में. और आप, क्योंकि मैं अपने घर बॉम्बे दोस्त नहीं मंगवा सकता हूँ, तो हम एक पोस्ट बॉक्स हायर करते थे और खुशखत की चिट्ठियां जो है वो पूरा जो बॉक्स में आता था फुल, और आप वहां से रिसीव कर सकते थे पूरा का पूरा. और सेकेंडली बांद्रा में आई स्टिल रिमेम्बर एड्रेस होता था 105 वीना बीना शॉपिंग सेंटर आउटसाइड बांद्रा स्टेशन. वहां पे एक मिसेस डिसूजा थी जिन्हें आज तक नहीं पता कि वो क्या कर रही थी, मगर उनके पास बॉम्बे दोस्त की कॉपीज होती थी. तो आप वहां जाके सिर्फ बोल सकते थे कि आई नीड बॉम्बे दोस्त एंड शी टेक 50 रुपीज फ्रॉम यू, और एनवेलप में डाल के वो आपको दे देती थी. सो यू नो, लाइक दीज आर ऑल pre-internet era जो हुआ करता था.
The point, he has a lot of stories to tell. You can perhaps ask him, and he'll charge money for Dastan going. But what I'm saying is, the point that I was driving home is that children normally hide. They were doing then, they're doing now. They're smart enough to wipe off the history from the from the computer or phone, chat history or the sites they've visited. So how do you break that, Subhash, that the children, we are able to talk to them, because health, pehli mental health hai, sabse pehle. How do we break that thing? That we need to work on, and from there we start. Thank you.
Thank
You
you.
can go
Thank
for
you
it.
very much.
Thank you for being part of my quiz, Vivek.
Thank you, sir.
Yeah. So thank you, everyone. Before we start technical session number 2, we would like to have a bit of a easing in back from the lunch session. So for that, I'd first like to invite Diamond. If you heard Shine on You Crazy Diamond, it is about him. Come. So Diamond is associated with our adolescent friendly center in Impal. He needs no introduction, but there is a song that Diamond is going to sing for us, which is called Kidaba Thawai, which is translates to soul warriors. So over to you. So this is the post-lunch session where we're expecting both participation and participants to go up. Or sorry, wrong context. On a Saturday. All right, so for technical session 2, innovations in prevention and testing, I would like to invite first the chairs and the co-chairs for this session. The chair for this session is Dr. Shobhini Rajan, who is DDG with NACO. Ma'am, please, if you can join us. Big hand for Dr. Shobhini, please. The co-chair for this session is Dr. Bhavani Singh, Deputy Director with NACO. Thank you, Dr. Bhavani. Big hand for Dr. Bhavani too. I will now invite the the panelists for this session. So the expert panel for this session is Dr. Rajesh Rana, who is Chief of Party for the Global Fund Program in Plan India. Thank you, Rajesh ji. We have Mr. Vivek Anand, CEO of Humsafar Trust, who by default is in every session. But had a tough time getting you to this one. Yeah. Dr. Rochna Mitra, Program Director with the India HIV/AIDS Alliance. Big hand for Dr. Rochna. And we originally had Dr. Asha Hegde, but unfortunately she couldn't make it. On behalf of PATH, we have Ms. Abina Aher, who will be representing Dr. Asha Hegde. So big hand for Abina again. We have two presenters in this session. The first presenter is Dr. Jalpa Thakkar, who is the Program Director with Accelerate. She's also been instrumental in spearheading our work on HIV self-testing, the virtual platforms, and PrEP in the private sector. So Jalpa, please join panel. Big hand for Jalpa. And the other speaker is Mr. Ajay K. Reddy. He's the MEL Director with Accelerate. He heads pretty much all the monitoring and evaluation work. He's also the most popular member of the Accelerate team because of the fact that he works in M&E. I think all my jokes are falling flat today. So Ajay will be talking about index testing and social network strategies. So without further delay, I will hand over to the chair, Dr. Shobhini. And Dr. Shobhini, the facilitator notes are here. We are expecting 15 minutes per presentation and then 2 minutes per panel member. Enough time for questions. If we have, we'll take from the audience, and then hopefully a summarization by the chair and co-chair. Thank you so much.
Thanks, Aditya. And I think we see enough energy in the room, especially after the song. So perhaps I'll ask you all to just do one round of good clapping before we begin. Yeah, thank you. Thank you. So I'd like to now invite Jalpa to make the presentation on interventions for virtual online population, Save Zindagi, HIV self-testing and PrEP. Practically an all-in-one kind of a prevention and testing innovation. Over to you, Jalpa. So 15 minutes as Aditya has tailored.
Sure, thank you, ma'am. And before starting, since I'm sure I'm going to have very little time in the end left, I would like to thank the entire team of Save Zindagi platform. Of course, Yes for Me and Linkages and USAID for giving us the baby platform that has now evolved. And all the team members on the state, in the district, and the community members who have worked with us, and most importantly, the beneficiaries who is able to teach us what we can take forward as a part of our national strategy for virtual interventions. So with that, I would like to start with the presentation. So we all know, and NACO has now repeatedly in its actions and guidance told us that it's time to move virtual. It's time to reach the last mile. Everything is changing in terms of the categorization of population, the place where we target and provide our services, and the entire horizon of our HIV/AIDS and STI services. So we all know that most of the people are now online. the mobile penetration globally and in our country is at its max right now with the national, digital health mission going on. And we also know that India has the second largest number of internet users, and that provides us with a great opportunity to go and meet those people who wouldn't actually be preferring to come to the traditional facilities. And that's why we see the gap of still 21% in our first 95, which then cascades into our second and the third 95. With that, we have tried to build a platform. Like I said, it started with the S4Me, and now it's evolved into a comprehensive, integrated, very safe, non-judgmental platform where we can cater to not just the traditional key population categories, but also those who do not categorize themselves or do not identify themselves into those categories and still are at high risk, are vulnerable, are young, and would like to seek those services to keep themselves safe. So the picture on the left we see is actually just a snapshot of the homepage of Safe Zindagi. And the figure on the right, which may not be very visible, is from the latest UNAIDS policy on the virtual intervention. And we have tried that the platform kind of replicates this particular policy, where we have the platform catering to different population. Like I said, it's not just virtual, right? Like sir has said, ma'am has said, it's always virtual to like online to offline, offline to online. And that's why this platform has been built in a way that we collaborate with the community who are in the physical spaces, but have a huge network in the online space, and gives us that opportunity to work with the community, even if this is one integrated online platform. So what services? So again, I would like to also thank our partners who've helped us develop this platform, RAGE. Some members are here today. These are some snapshots of the pages on the platform. So it is an entire care continuum, right? So right from prevention to testing with a bouquet of services for testing. So it could be either testing through labs, testing through ICTCs, testing through other NGOs such as the YRG Care ICCs, or it could be in the private laboratories. And the client now also gets an option of choosing HIV self-test if they really can't make it to that physical space. And then after the testing, we have the services for linkage to either prevention or treatment based on the results of the screening on the platform. So we have the PrEP platform integrated within, so the client does not have to go around. It's on the same platform, and the client goes into the same journey as it started before. And if it is treatment, we have linkages to the private sector and to the ERT center and further follow-up, which is also very interesting. I'll come to that very shortly. So to give a brief, these are the very critical components of the platform that we call as integrated. First being, it is a landing platform, right? So we have many, many various outreach platforms, outreach channels. Again, we'll talk about it in a minute. And wherever the client sees this service or hears about it through any of the outreach method, we have a common landing platform, right? On the landing platform, like I said, we have choice for testing services. There's home collection, there's walk-in, there's self-testing. We have treatment services. So like I said, we have linkages to various facilities. We have prevention services, not just PrEP, but the entire combination prevention methods, which includes counseling, providing access to condoms and other safe sexual practices in collaboration with the community. So the community collaboration really helps us to take this online intervention offline and bring the offline clients. So basically those clients who would want to seek services little more confidential on the online platform, but cannot really navigate on the online platform, we have the community to serve them and to help them to seek these kind of services virtually. And then the virtual counselors, very important part, a very important prong of the platform. We have a team of 12 virtual counselors. Some of them are present over here. So thank you for them to take this journey so nicely ahead. And they actually provide the entire assistance to the client, right from choosing the service, which service is right for them, adherence to the services that they choose for, linkage to the right facilities that the client may require based on the testing or any other service that they choose. And the platform also aims to reduce the stigma and discrimination, and hence calling it a safe platform by constantly providing personalized counseling through the virtual counselors and the community that we collaborate with, and by publishing the latest information in the most layman language on the platform. So a lot of literacy material on the platform and a continuous online chat bot. So there's a WhatsApp number, and the WhatsApp directly takes them to the team members, the team of virtual counselors who can give answers to any of the queries that the client has. And finally, the platform provides a little bit of artificial intelligence in a way that they can book an appointment, they will get reminders based on the booking that they have done or the last service that they have taken. So if the client has completed a testing, for example, then the next step could be either PrEP or ART. So those kind of reminders easily are pushed from the platform to the client and even to the service providers who are our virtual counselors to follow up with the client so that we have very less dropouts because it's difficult to retain the client on the virtual platform. And finally, it also helps us manage all the data and documentation. So it is an integrated information system that gives us readily, like I said, all the reporting, all the program monitoring happens on the platform itself. I think this is, again, what I said, that a client could be a new client or an old client. So this is just a journey of what really happens. So at the back end, it may look a little complicated, but for the client, when they enter the platform, it's a very straightforward journey. So from whichever outreach platform the client comes, they have to log in with their mobile number, which helps us reduce the duplication as much as possible. And it could be a completely new client who has never sought any services or an existing client. So the new client, based on the risk assessment and the requirement, goes to any of the services that they want or can go through the entire care continuum. And the old client or the one who has sought service before will be nudged to go to the obvious next set of services. So how did we actually reach the right population? And again, this is important because, like Sunil had mentioned earlier, the positivity by testing through the virtual platform is as high as 7% for us. So we have numerous outreach platforms. And for those platforms, there are many other strategies, or I would say channels, to use those platforms, right? So platforms, I think all of us know there are dating applications, there are a whole lot of them. And of course, there are some leading ones like Grindr and Planet Romeo and Blue. Then there are messengers, very, very important. WhatsApp and Instagram messengers and Facebook messengers have proven to be very, very effective in providing the right education. And we've seen a high conversion from these platforms altogether. And the social media applications like Google Network. So advertisements, right? So among the strategies, we see there are paid and unpaid ads. Well, the conversion from the advertisements to actually a client seeking a service may be low, but it really helps disseminate the right information, the right education, and very importantly, credibility, right? So the more the person sees about the services, about the platform, about the organization, the more credibility it acquires, and hence more complete confidence and rapport with the virtual counselors to seek the services. And with all of this, I think there's a huge lot of materials that we use in various forms. With all of this, we've been able to reach more than 150 million people online, of course. And this is reach means those many people would have seen this kind of information. Out of that, 1 million did click on a certain service to know further. And right now on the website, that is savesindagi.in, we have 74,000 users. So there in achievements, we would like to take you through like a few things, such as overall testing, and this includes testing through physical sites, that is laboratories or ICTCs, and also the self-testing. So in overall, we've had about more than 15,000 registrations. But if you see the second bar, the testing is more because these services have been going on for the last 3 years. And then there are 5 to 7% of repeat testers who would go for service again, for a testing again after 6 months. And we see the positivity as high as 7%, both combined, if you look at HIV self-testing and the traditional way of lab testing. And we'll go into this graph a little bit more in the HIV self-testing platform, but overall linkage to the confirmatory testing is also 80%, and those who are confirmed, and all of these are confirmed at an ICTC. So those who are confirmed, 85% of them have been linked to ART and the treatment has been initiated. This number, again, previously, when we started off, was as low as 50%. So it required a lot of counseling, a lot of trained personnel who were sitting on the, in the office and counseling virtually. And providing that support by building the rapport with the ART centers, counselors over there, treatment buddies over there, that we were able to reach this kind of linkage. Just a snapshot of where the testings are happening. So in terms of physical spaces, there are 3 main providers. One is, of course, the ICTC, second are the private laboratories, and third are the YRG care supported ICCs. Again, that's under a project, so it provides free services. Some of them are also co-located with an ICTC, but the only advantage is that there's lesser crowd and there's lesser waiting time over there. So most of the clients, as we see over here, 80% have preferred to go to the ICCs, but there is 12% of them who have still gone to the private sector and the remaining to the ICTC as well. So there is potential over here to kind of expand the network with private sector and the ICTCs. Again, so Safe Zindagi, through its testing platform and the PrEP platform, has been able to reach more than 40 cities in India. But this is to show that if we have to, like Sir was saying, optimize the cost and make it more effective, we do know where most of our clients are. So these are the list of about 15 cities. So the first graph says where the maximum number of testings are happening, and the second graph is where we have seen high positivity. There is a match between the both, but there are a few new cities that come when we talk about positivity. So these two combined could be our focus areas as we go forward to invest our time, money, and resources. Moving on to specifically to HIV self-testing. So like Sunil mentioned, self-testing was initiated in June 2021. It's been over a year now. And it came very handy when, again, the COVID struck us, the last wave. And a lot of clients appreciated this service because they could really not go to the lab at that point in time. So I will now start a video which will actually take you through the platform.
Jalpa ji, 3 minutes.
Order a new HIV self-testing kit. Go to www.safezindagi.in. Order a new HIV self-testing kit. Go to watch the exclusive video explains more about HIV self-testing and get answers to your concerns and questions. Watch the exclusive video explains more about HIV self-testing and get step-by-step guide on how to administer the self-test and get professional support by speaking to our V counselor. Step-by-step guide on how to administer the self-test and get professional support by speaking to our V counselor. Click on Order Now from the drop-down WhatsApp or email from the home bank to get your doubts clarified. Your mobile number and get OTP from the drop-down menu. Eligible from the home bank. You need to be eligible to use the HIV self-testing and get OTP. Click on the checkbox if you are 18 years and above to be eligible and your HIV status is negative or unknown. Click on the checkbox type of delivery and above mode of delivery. Either get it couriered to a desired location or pick it up from a nearby pickup point. Virtual assistance. You can choose to have assistance from the virtual counselor while testing by selecting pickup point. Virtual assistance to continue. You can choose to have assistance from the virtual counselor. This is your last step. Testing by before we proceed, your consent is required to continue. Read through and give your consent by clicking on the checkbox. But before click yes if you would like to receive a link for sharing your valuable feedback. Clicking your order details will be sent to your registered mobile to receive a link. Go sharing account to access your dashboard. Your order check your risk status and take the next steps to a risk-free life. Go to my account on order ID your dashboard. Order details, check your risk status and to upload your test results to a risk-free life. Upload your HIV self-test results to view order details, appointments, and to upload your test results will be validated by a V counselor who will advise you on the next step. Same tab. You will be taken on the PrEP treatment or by the ART journey who will depending on your HIV self-test result. You will be for more information on HIV and HIV self-testing, visit www.hivselftestresult. For more information on HIV and HIV self-testing, visit www.safezindagi.in.
I think the important part over here is to look at the third bar, which is how many clients actually took a kit and then reported back their results. And that's as high as 94%, which is very high as compared to any other global interventions we see in HIV self-testing. And this has been possible. We also did a client feedback survey with about 300 clients. And 90% of them said in the survey that it was very easy to go on the platform and upload the result. So it has been kind of validated with the feedback as well. And similar positivity and the linkage we see over here as we saw in the previous graph. Again, this is just to give an idea. Mainly, if you look at the age graph, the median age for testing was 26 and for positivity was 27. And in terms of gender, yes, we've been able to reach more male population. But again, there is a scope since 13% and 7% of them were females and transgender. And 7% refused to show their gender to us. I think the next few slides are just an analysis to understand. We have in the model, like you must have seen in the video before, we have types of delivery, right? We have types of acquisition. So if we see amongst all the population, the positivity remains constant, which means that we need to do a lot of more work to reach the transgender and the female population through this particular intervention. Again, in terms of acquisition, those who came directly, those who came through virtual counselors, those who came through our pickup points, which are actually community-based organizations. Again, there has been almost the same. We see that direct registration means the ones who actually came by looking at an advertisement somewhere or on their own by hearing somewhere. So even those population, like 49% of them were actually coming without any further efforts. Similar thing for delivery, either courier or pickup assistance. We see that those who were 33% actually chose unassisted. So it actually shows that self-testing can give that opportunity to them to do the testing on their own at their convenience. And more than 95% in the survey said that the best part about self-testing was that. So this is, I would only want to read out the client feedback over here. We also did like a qualitative survey, and 41 clients actually gave their feedback on what they thought about the program. So they say that they do not actually, these are all working clients, so they do not have time to think about themselves and health. Sometimes you are engaged in risky behavior, but we ignore it. At least with this self-testing kit, we can clarify our doubts. If this test result shows some problem, we will get a hint that we need to do an actual confirmatory or a proper checkup in a center. So this is through a transgender individual. Quickly, I know I'm shooting over time, but I'll take 5 minutes from Ajay's presentation.
You had already spent 3 minutes of that also. 3 minutes.
I know Ajay will allow me that.
2 minutes बचे हैं बस.
ठीक है, sir. And so the last component, which is again a very evolving and an exciting component, is that of pre-exposure prophylaxis. Sunil has spoken very nicely in the morning, so I'll just brief through it. So these were just the steps on how in 2016 the PrEP medicines were introduced in the Indian market. And then finally in 2020, we actually could roll out a small pilot that can give us some understanding on what model works in the paid sector or in the free sector. So the components of the PrEP online platform remains the same. Two important things over here are the network of subsidized laboratories for providing the baseline testing to the clients, and second is telemedicine. So all the consultations with the doctor is completely online, and the client really doesn't have to go anywhere. Now on the right, we see is the collaboration with the community. These are the community-based organizations who are not associated with the program, but have a huge network on the online platform with the community. So quickly, like this is the client flow. It's pretty much in accordance with the national guidelines and also the WHO guidelines. So there is PrEP preparedness through the counselor or through ORW. Once the client gets convinced, is willing, and the risk is there, is eligible, the client then actually undergoes the baseline testing through one of the network labs. Over there also, we have sample collection transportation there. So those who really don't want to go can take that service. Then comes the doctor appointment. So if all the levels are normal, the doctor will actually go for a prescription, and then the pharma goes to the, and then the client goes to the pharmacy and picks up the drug, or even that gets couriered and delivered. So it's basically the client sits at home and gets all the services. So on the left, I mean, this slide is mainly to show that there are certain units that give the, outreach, demand generation, counseling. Safe Zindagi platform being an aggregator, so all the clients will land over here. And then on the right are where we provide the services through doctors, through laboratories, through community. One very important aspect is counseling, adherence, follow-up, right? And retention on PrEP. We haven't been able to, like, none of the publications right now also give us that understanding, but we are trying to see over here that once the client starts on PrEP, after 1 month, they come back for follow-up, for HIV testing and for refill. And then even after they take medicines for 3 months, our virtual counselors rigorously follow up with them at least every fortnightly or monthly to provide adherence counseling like we do for, the PLHIV. So we do see in the numbers.
So Jalpa, please do summarize in the next 1 minute.
Done, ma'am. So we do see here, and I think we've seen this slide already. Only thing I want to highlight over here is that we see 74% retention, and most of the reasons for stopping PrEP, like Sunil said, was risk mitigation, and some cases we also see fear of taking medicines and affordability. Again, over here, in terms of age and gender, we see the same results like we saw on the other platform of Safe Zindagi. And geographies, again, for us to focus in those specific 10 cities. So that's from my end, and thank you very much.
Thank you, Jalpa. If I can request you to come back and join us here. I am going to reserve comments to the very end in the interest of time. So we'll call our next speaker, who is Mr. Ajay K. Reddy, to talk about index testing and social network strategies. So you have, let's say, 12 minutes.
Good afternoon, everyone. I would present our experience in implementing index testing and social network testing, which also complement the regular testing being done under the national program. And we optimize from the opportunities present themselves at both ICTCs and ART centers. Also, we introduce something new in terms of network testing to cover key populations. A bit of a background. As Jalpa said, with respect to the UNAIDS goals, India still lags behind. Around 23% still PLHIV, estimated PLHIV remain still undiagnosed. So that means we need better efforts or more options towards diagnosing them. And some of the key challenges could be self and family stigma. People don't want to get tested because they feel that accessing facilities, it may not be facility-based stigma or from a service provider, but self-stigma also drives them not to test. Then logistical challenges, these testing facilities may be far or lack of testing options. With what Jalpa has presented, we now have better options, but earlier we used to only go into a facility and that was the option, and with a TI for the key population. So these could be some of the generic challenges in terms of populations or subgroups of populations who don't access HIV test. Also, I want to highlight that we try to increase the number of tests in many modalities. We increase the number many a times, but most of the times it doesn't lead to diagnosing more people. So that means that we need more targeted testing depending on subgroups who are at risk. So Accelerate is complementing the national program with 4 types of testing, 2 of them which Jalpa has already shown you now in terms of virtual testing, catering to a specific population who are young, mobile and tech savvy, and also self-testing, people who don't want to come out in facilities and other places. But I would like to give an overview of index testing and social network testing, which we implemented over the last 3 years. Okay, first we will go through the index testing. It's not, index testing is not much different from what the national program mandates, but it expands the testing to not only spouses and children, but also to the sexual partners. So that's one of the key things which index testing really aims at doing. It can be implemented with using both the new and known PLHIVs. That means both the ART centers as well as the ICTCs for the newly diagnosed can be used to implement index testing or tracing contacts and testing them. One of the key things was compliance with 5 Cs, which respect to it should be consent should be there, both of the index and the contact. It should be confidential. We should put in places where confidentiality is ensured. Counseling is key part, both for the negatives as well as screen positives, and aim at giving correct result, as well as linking them to appropriate services based on their status. If they are negative, should be linked to prevention services. If positive, linked to treatment services. But most of it also entails looking at aspects of violence, either both for the client, but also sometimes contacts. So if names are revealed, identities are revealed, there is a threat of violence. We need to put in mechanisms where the responses are there and clients and the contacts feel safe. And also that means that implementers who facilitate this need to have standard operating procedures. If certain situations do occur, how to deal with them in terms of mobilizing contacts as well as clients. So this is a process how we do index testing at both at the facilities. Basically, it starts with introducing ourselves to the client, getting the consent of the index client, then listing of children, partners. Partners include spouses as well as needle and sexual partners other than spouses. Then conduct risk assessment, IPV assessment. If it is a higher risk of IPV assessment, then determine process to mitigate that. But if the risk is not there, then look at options of notification and options for testing of clients, whichever is based on the preference of the contacts elicited. Then the next step is following up with the testing at appropriate facility, then linking them to prevention and treatment services based on their HIV status. Yeah, seems simple, but it takes a lot of what we have experienced over the last 3 years is the time taken to convince, elicit, and test people is really, it takes a lot of effort. First to gain confidence of the people, to give the contacts name, then mobilize the contacts, look at appropriate testing options, at least get test, and then link them to treatment. So I want to just share the index testing cascade, and this is for a period from September 2019, September 2020, almost 3 years plus month. It was implemented at around 100 plus facilities and multiple community sites in 10 districts across Maharashtra, Andhra Pradesh, and Telangana. So Accelerate phased out from Andhra Pradesh after year 1. Maharashtra, we continue for the 3 years. Telangana is, we just completed 2 years. And also multiple community sites, we implemented this with known positives. So just, I'll walk you through the numbers because this is done at scale and proven at scale. And it's not what we are trying to experiment or results are. So irrespective of whatever the setting, the results were consistent and very high. And if we are really wanting to bridge that gap, I think this is one of the key models which we can look at. So we offered index testing to almost 36,000 index clients over the 3 years. 93% consented to participate. We elicited almost 59,000 contacts, with 6% of them being positive, already known positives. 92% of those negative contacts, which is almost 52,000, agreed for test, and 49,000 plus contacts were tested, facilitated to be tested with different ICTCs and community-based testing. Overall, we got 9,400 plus positives with a 19% positivity. None of the, I think, whatever testing modes or methods we have implemented, we don't get these kind of positivity. And the positivity was irrespective of settings, the contacts, the sites. So if it was facility-based setting, it was 21% positivity. Community-based setting was 14% positivity. States were consistently, Maharashtra, we got 21%, Andhra Pradesh, 29%, Telangana, 17%. Type of contacts also, sexual partners, 24%, spouses, 21%, children a bit lower, 8%, still very high.
So, 3 minutes.
Yep. And the highest positivity was in age group 30 to 35. And as the age increases, the numbers may come down, but the positivity was higher. And also, we also did the costing of these. If we have got such a success at scale, we looked at costing, whether it's possible to integrate that. We didn't have comparison to our costs in Indian settings, but when we compare it to other similar countries, low and middle income countries in PEPFAR settings, it's on par or cheaper than other countries. And also year 1 and year 2 costs came down drastically, and the major cost was human resources we employed. A way forward, we would try to advocate for the inclusion of index testing into the national program. We would like to train and facilitate implementation of it at scale. Also would like to introduce you to social network testing. We just started, completed initially, and it's not as proven or at scale as possible, but the idea was to really look at key populations who are hidden and are not currently accessing services from the national program, especially the TIs. So social network testing engages social contacts of key populations such as sexual and drug injecting partners. It improves acceptability because it engages peers. It provides multiple options for partner notification and ensures confidentiality. And what we recruited, we implemented this at 15 sites. We recruited 5,000 plus key population across the 4 typologies, and lesser among pivots. As we know, in Maharashtra and Andhra Pradesh, the pivot number is less when you look at the other curve. And if you look at 3 aspects, self-reported exposure to TIs for FSW, there were only 45% they reported exposure to TIs. That means there are still other FSWs. Similarly, for MSM, only 19% reported exposure to TIs. For TGs, 21% and pivots, 22%. So there are enough scope to really scale up this approach and reach out to them and provide testing services to them. Similarly, for whether they were first-time testers or repeat testers. So most of them, 36% were first-time testers for HIV, though being key population. So that means there is scope for really testing out them. FSW, lower number of first-time testers, which is 14%. MSM, half of them, MSM and TGs, half of them were not even tested for first time. And pivot, still higher. So enough scope to expand prevention services, enough scope to provide prevention service. And also positivity, if you look at it, 7% among FSW, 9% in MSM and TG. That means we are catering to higher risk key populations. So this methodology would enable us to reach them, but it's now to design appropriate, flexible prevention testing and other approaches to really bridge the gap. Similarly, we want to now use this information on risk, their geospatial location to roll out services to bridge the gaps. If possible, we would like to integrate that with TI's way of working, how they can use this, look at high risk, capturing high risk key population, and we would be ready to build capacity to implement the approach. Thank you.
Thank you, Ajay. Before we go around to take comments from all the panelists, I'd just like to make some very generic comments, maybe not perhaps only limited to this session. And there, what I'd like to say is that in the program, we have moved from a situation where treatment was largely a facility function, a specialized function, and prevention was largely a community function and delegated to outreach workers, peer educators, and perhaps, counselors outside of the program. So once you entered the facility, the role of counselor started with pre-test counseling, where he would be linking only to the HIV testing process, and then finally identifying someone, detecting someone, putting him on treatment, and thereafter. But I think the way that we have moved, wherein we have community-based testing, we have screening, we have self-testing, and testing available at the private sector. So saying that testing and treatment is only limited to the interventions that we are doing within a facility, or saying that prevention is limited to something which we are doing only in the community, will no longer be appropriate. And I am really glad to see that majority of the interventions that we saw since morning do capture this, but there is still scope to make them 360 degrees. So this would be a broad, comment from my end. And I see the virtual interventions as a certain area where this 360 element actually exists. And this element can be further strengthened, and we can leverage much more out of the virtual model than we probably presently are. So with this generic comment, I'd first like to call on Dr. Rajesh Rana to make his remarks. You have 2 minutes, but we'll give you 1 minute more. And that holds for everybody else. Yeah, the 1 minute grace will.
Thanks a lot, ma'am. Great thanks to Dr. Jalpa for presentation as well as Mr. Ajay. And when Jalpa was presenting, so I could easily say that how does 5G works. You know, it was so fast. Duck, 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 duck. And it is actually the need, yeah. It is actually the need of the hour. And if you go, the first G started in 1980. The first HIV case was detected in 1981. And we are in 2022 and we are in 5th generation network. So probably we are matching with the pace of how network is changing and how we are changing our speed in terms of when we're talking about new intervention, innovation about HIV. And if you talk about the communication part also, if you see the complete pie, the traditional mediums are getting lesser pie and the virtual or new mobile innovations or the things are getting more pie. So it's really important that how we face, how we go with such type of innovation so that this running and catching each other is matching there. The important part is because we have seen such type of interventions and we are having different approaches in different part of the countries. The best is how to integrate. First, second, how to scale that. Third, how we have to keep in mind the regional context also. Because I was present in one of the consultations where participants, they came from different part of the countries and what they told that it's not only that one particular social networking app is available, we are having region as well as religion specific also. Yes. So it's really important that how we are matching with that. So this is something which is really innovative and which will definitely going to pave a new way how we have to reach to the last mile. Last week, no, day before yesterday, I was in Andaman. So we have one ICTC in Nicobar Island also, right? So probably we have to reach to that last mile also. So that is really important. That is only possible when we are having not physical interventions, but virtual interventions. So how the networking needs to be done, that is really important. And when we are doing all these virtual interventions or different innovations, the important part is confidential. How we are maintaining that. That is also something which is really, really important. And last but not least, I remember whenever we used to do any campaigns, we used to sensitize all these editors or media houses. So do we need to have a platform where we can bring the social networking site operators all? Otherwise, those who are really influencers, how do we sensitize them? How do we need to bring them on the platform, or how do we need to bring them in the program so that they are equally sensitized and they can also be enablers for us? So with all these things, really great work done by GHU under Accelerate project and good presentation, 5G presentation by Dr. Jalpa. Thank you very much.
Thank you, Dr. Rajesh. Now I will request Dr. Roshna Mitra, Country Director for Alliance Union, Program Director, I think. Yeah.
Thank you, Dr. Bhavani. Good afternoon, Shobhini ma'am, Dr. Bhavani, and all panelists. I think virtual space interventions are a very new thing, but that's the way to go if we have to reach the untapped 23% or whatever the percentage is for people to reach particularly the young population who are very active in the virtual space, but also have a risky risky behavior. So as part of our Global Fund supported grant, Alliance is also through Hamsafar Trust doing a virtual intervention project NetReach, and it's a pan-India project. And what I would like to emphasize and stress on what my earlier panelist Rajesh has emphasized, that integration has to be the key. Because, we are all doing work in several geographies in our own way, sometimes, following the donor mandate under the guidance of the National AIDS Control Program. But, unless we integrate, we will not be able to kind of, show results. And also, as in the morning, if we all remember what DG sir had said that, models which are scalable, replicable, economical, and ultimately sustainable, because we all have a shelf life that ultimately it will transition to the government, and we should present to them something that, they can carry it forward. So that is, I think, very important when we are designing interventions or when we are doing interventions. And also, as far as numbers are concerned, since NetReach works pan-India, of course, the numbers reached are higher, and also the challenges are also higher, because, each state has its own dynamics. Virtual navigators, the term that we use in NetReach for, like counselors, as in Accelerate, they have their own challenges. But the net thing is that, it's an evolving thing, and, we are learning things every day, in fact. But unless we meet, integrate, see how we can do the, do the programming properly and in a sustained manner, and also learn from each other. So I think that's the way to go. And NetReach has been showing some successes, which of course Vivek is here, he will talk about. And of course, the challenges as well. But overall, I think it's a great intervention, and it's the future for kind of reaching the unreached. Thank you so much.
Thanks, Dr. Rochana. So without much ado, logically it goes to Vivek Anandji.
Okay, so yeah, so Rochana, I'm not going to talk much about NetReach. Odd लगता है, अपनी तारीफ कर रहा हूँ. So, but yeah, I look at, a good prevention strategy, a good intervention as something that's a combination of online, offline, and a helpline. Okay. In 2010, I was 49 years old, and I realized I didn't understand the language of the youth. I honestly didn't know what LOL stood for. But I spoke to my board, and we set up a youth group called Yaria, which is 18 to 28 youth. And today Yaria is 10,000 plus youth. It's an online, offline forum, both. They started only as online, became offline. For me at that point of time, it was very, very important that I wanted to hear to the voices of the youth and what do they say. And in 2013, we launched our first online intervention, which eventually led to the setting up of NetReach. And by the way, thanks Sunil a lot wherever you are, because if you remember 3 years ago, Vinita and you got me here in this room for the first time. And this first time I met Shobni and Alok sir. And I said, we want to set up this online intervention program for MS and transgender. That's all. So today, yeah, it's 3 years of togetherness. And thanks Shobni, thanks Alok sir. And so yeah, going back to my point. So it was in 2013, we decided that online interventions are needed, and we started a small, we had one outreach worker. We really didn't go in a very proper, structured, systematic way, but we are reaching out with messages. That happened. Then a lot of things happened. Ajay, what I appreciate a lot, because without knowing, I've been talking to my teams about the social network model. Because a couple of years ago, if Sumita's here in the room, you remember in linkages, we had tried EPOA. And I truly believed in it. I truly believe in social network, because I feel that's a great innovative way to reach out to communities. How we can tap into people who are not visible. But eventually what I feel that you may reach out to me online, but somewhere at the end of the day, I need a human contact. I'd love to see Archana as my counselor, because I want to talk to her. I see a human face. Sorry if I sound like what Alok sir said in the morning. Okay. Yeah, I want to see people. Okay, it matters. Everything can't be online for me. I'd love to talk to someone on a helpline. But if there is an intervention which is online, I would love to come into an event. And I'd love to see, acha, aapne Safe Zindagi ka ye dekha? Did you see this from NetReach? This is where you go for a test. I want someone to tell me that. Do a bit of hand-holding. Maybe the new generations are different. What I would like to see more of, in these prevention strategies when we talk about it. I'd be very happy to see, and Murgesh, that applies to your net reach to begin with, Bacha, and our net reach, and that applies to you, Jilpa. I'd like to see more, some more about what is the mental health data that is available to us. I did not hear much about mental health, you know. Yeah, these are great interventions, these are great prevention strategies, but are we reaching out? Are we covering those mental health issues? How many people? Because COVID made us realize one thing, that today, like, we are really getting money to have 4 online counselors. My online counselor is overburdened and her bills are overburdening me. But it is needed. It is, and that's what COVID taught us. You know, mental health was always an issue. So I'd love to see more of mental health. And also one thing, what I see missing in the innovative prevention strategies is the engagement with the youth. And I apologize to all you youngsters sitting out there. I feel as a 60 plus, I have no business to be sitting here deciding what the 20 plus needs. It's your world. You need to decide. Like, I'm personally very, very scared of self-testing. But just 3 days ago, I was talking to this 25-year-old boy, and he said, self-testing is available. ऐसा होता है? I said, of course. He said, sir, I'd happily take that self-test. मुझे बीच में confirmatory test का आप निकाल दीजिए. Remove that one factor. Just tell me you tested positive. Go for your treatment to this place. He said, but I don't have any issue. He said, like, COVID में भी तो हम self-test लेते थे. It's one of the largest self-testing thing that works. So that's what a 25-year-old boy is asking. Let me not decide that I'm scared of self-testing. It's not me, it's you. So that's one thing I would like to see. Engagement with the youth when we are talking about, you know, innovative prevention strategies. Let them talk. You know, let them come forward. Let them say that this is our need. Right, Sonal? Correct? Yeah, that's my girl out there. So these are 2 things, you know, that I would see going forward. More of mental health information, to much more engagement with the youth of today. Otherwise, I go back home and I come in for a lot of criticism. आप क्या वहाँ बैठ के बोल रहे हो, मुझे क्या चाहिए? Sorry, I'll avoid that in future, but thanks. That's about my comments.
So I will request now Ms. Abina for her comments and observations. Thank you, sir.
Hello, check. Thank you. Thank you so much. And I'm representing PATH on behalf of Dr. Asha Hegde, who's our Deputy Director for HIV, hepatitis, and COVID. You know, I just want, first of all, thank you so much, Dr. Jalpa, Ajay sir, for a fantastic presentation. It has a lot of learnings from that, and I could relate to our program. The program that we are implementing with CDC PEPFAR right now is in Northeast and in Maharashtra, Mumbai. And you know, when we talk about Northeast, everybody understand we are driven by several issues, right? We have a political instability. We have issues when it comes to the communication over there. We have concerns about, you know, a generalized epidemic that we are working around with when it comes to Mizoram, where the epidemic is all spread across. Border security issues, corridors, all those kind of things. So, you know, some of the things that you talked about, and I was just trying to relate to it. One of them is the HIV testing. Everybody talked about elaborately. And as PATH India, we have done a huge amount of work on self-testing under Sahay project. And right now we are into a process where we are trying to put up a social media campaign on that. And I think this is something which needs to be taken forward. So I congratulate Accelerate also to work in that regard, and together as a partner, we can really do a substantial work. I think that is something which we need to work around with that. And as aptly our work talks about is that your testing is in your hand. That is the next generation, the Gen Z people, the Gen X, Y people probably would say that, you know, the services that they want to have it in their hand. It's like as simple as having a COVID test, you know, where you don't have to wait till the time the COVID test result comes, but you can act upon it the moment you come to know about your risk vulnerability. The other thing about that, some of the things that I was talking about, and we've been working around with that, is that, you know, safe passage of vulnerabilities. So we have identified the issues about the migration, which is an amazing thing. Recently, we did a lot of work on CBI. CBI for me also was a big thing, the cross-border intervention, which understanding the cross-border interventions among the countries, like because we are situated right at the Myanmar border and Burma border. So there and the interstate like Tripura, Assam, and other things where the vulnerabilities are working around with that. So I feel these tools that we are talking about, especially SNM, self-testing, how do we use that over there for these kind of work that we are around? The second thing I want to talk about is engagement or a bigger policy makers and stakeholders into the work that we are doing. So when we are talking about self-testing, when we are talking about SNM, it's just not about the key communities, right? It is also about the engagement of faith-based leaders, engagement of other people. Like in Northeast, we have to work with engagement leaders because we are dealing with tribes. It's a big thing, and churches play a very important role into that regard. And how do we work around with stakeholders is something that I was working around with that particularly. Of course, youth centers and youth engagements are very important aspect. And as Vivek sir talked about it, that you can't do anything without youth because we are talking about early infections. Early infections, if we deal with it, we do understand that is directly deal with the first 95 and also it contributes to the second 95 elaborately because you are bringing the epidemic down. That is what our focus is, right? When we talk about 2030 target, unfortunately, in fact, I feel that we have to have a separate targets for youth, particularly when it comes to the HIV interventions, because that data disaggregation is missing around with that. The other thing I want to talk about is approach on the granular analysis. So many times we do implement program, but we miss out on a granular analysis. And when we are right now implementing in Northeast, we are seeing district interventions as a very important strategy. So taking districts and doing interventions based on the granular analysis. I think Devraj sir is here from Maharashtra, I guess. And I think Thane and other things have done this kind of work, which is a very important approach that we can really take forward on the work that we are talking about. And I think digital access to the services, which is very important things we also have been doing in Mumbai. In COVID times, we started something called as ART Mitra, which was an online platform for people to easy access for the ARV medications. And we are also starting online DIC, where the youth and people who are on the digital platform can easily access the services without they going to a spaces. But at the same time, having said that, we are talking about the digital innovation, digital access, but still 80 to 70% of population is on the field. We cannot forget them, right? We cannot move out from them. And I think there the SNM model, which is a hyper model, hybrid model between SNM and index testing does make matter. Because you can't just have a silo approach that, okay, I will only go for SNM or I will go for index testing. In certain areas, certain population, you have to modify those approaches appropriately for you to work around with. Again, where we are talking about virtual to virtual and virtual to in-person modeling. So that is something that I wanted to talk about. Thank you so much for this opportunity. And we are also trying to engage on NCD and mental health very elaborately. That's a good learning for us as well. Thank you so much.
Thanks, Abhinav. I think you brought in what CDC is doing to kind of complete the picture. I'd now request my co-chairperson, Dr. Bhavani, to make some remarks on both the presentations and on the stands.
Okay. I thought I was for timekeeping. No. So, yeah. So after hearing everyone, I don't think much has left unless until Madam says something. But only thing we have to keep in mind that the good work and innovations done pioneered by, in fact, Accelerate, and also being done by different projects. Almost 4 partners are working in the virtual sphere, and regularly we are coordinating with them. But to say that only virtual intervention will work at this point of time, what? won't be correct because the volume is still on ground, and somewhere what ma'am always says, there should be a linkage between virtual to physical world. And one thing we can always take forward after this symposium is that we had seen that each partner has mapped some private practitioners also. So that mapping of private practitioners of facilities, be it mapped by NetReach or Save Zindagi or VHS, those should be at one place, and those this can be shared across also. Because if someone comes to Save Zindagi from apart from those 40 cities where you have your network, then at least they can avail services. So something like that should be thought of. And one critical thing which we discussed during our partners meeting, and that need to be taken forward is what ma'am always guided was that loop does not complete at testing. They came there because they are at risk, and there should be some kind of follow with them, how, when, how many times, that we have to explore. But that follow up should be there, which is completely missing across different platforms right now. So our virtual counselors have to focus on those things then. And as far as index testing and social network approach is concerned, already under revamping, we had included, but yeah, the trainings of TI is not up to that level. So maybe in the geographies where partners are there, they can take it up. Although in the concentrated way, we had identified our Shamta Kendra. There are 19 Shamta Kendras across India. And in next 4-5 months, we will start our training. These Shamta Kendras are something like STRCs, which were there previously. So there will be a system for the TI training next year onwards, and maybe this year, tag year. But yeah, index testing at ART center is one thing which can be take up strongly under NACP. I'm not saying it is not being done, but our counselors and other staff is still overburdened. So how we can do the task sharing or task shifting and focus on this critical aspect of index testing or testing of discordant couple at regular interval, that we have to take up. That's all. Thank you.
So thank you, Bhavani. I'd like to congratulate both Jalpa and Ajay ji for making very good presentations on what has been undertaken under Project Accelerate with USAID support. I do understand, Sunil, that this is not an end of project presentation. So the work is ongoing, and we will keep seeing maybe modifications in the design, as well as an increase in the reach and increase in what the outputs look like for us. So at the end of the session, I think most of the panelists have said what was to be said about it. I just have a couple of points to make. One of which is that when we look at testing, under the HIV program, we are looking at both the STI and HIV testing together. And with the advent of the dual test kit, which will probably be available in the field in, let's say, about 6 months time, it's already there for the NHM facilities to screen pregnant women. But it will very soon be available in the facilities of NACP for screening the populations who come to your ICTCs as walk-in clients, for the prison population, for the TI NGOs, and for anybody who comes to the STI clinic or to the Sampurn Suraksha Kendra. So at these locations, we are looking at bringing in the dual kit. So I'd just like to request the project partners to look at how is the landscape going to look like with the presence of the dual kit, because we can, in the program, I think we heard it very loud and clear from both Nidhi madam and Alok sir, that it is an HIV and STD control program, and we need to look at both the aspects equally. And having said that, we are actually exploring convergence for even hepatitis testing, which we are successfully doing in the surveillance program. But we are looking at doing it maybe across those geographies. Like if you have a camp for injecting drug users, then it does make sense to offer them all the tests at one point of time. So that's one thing that I want to say. The second thing is that under the National AIDS Control Program, you already have the HIV/AIDS helpline 1097, and we saw use of helpline for self-verified adherence, wherein it was informed that the call is made to the helpline. But in the virtual platform that we are having under Safe Zindagi, perhaps we need to explore some kind of engagement with the helpline, at least in terms of we have virtual counselors available across your project, and maybe, you know, capacity building of the 1097 counselors could, it some inputs from what the project has done could flow into how are we going to capacitate the 1097 counselors. And similarly, Sampoorn Suraksha, the way we are envisaging under the program is going to be a physical landing spot for anyone at risk, considering that the initial service that they will come for is a test. So it's very similar to what Jalpa you indicated as the virtual landing page. So maybe we need to understand the functionality in the operations of this. Right now, of course, it is a global fund supported project where we are looking at only 150 centers to be called Sampoorn Suraksha Kendra. But as a strategy, it is going to probably appear all across the program. So this is the second point I want to say. The third thing is that it is very interesting to see that the index testing did lead to something like a 21, did I see it right? 21% positivity, 19%. Okay. So there were ranges, there were 23, 21 across different population groups, across different settings. So that is indeed an opportunity. We, as Bhavani pointed out, we have in our guidelines for TI revamping incorporated both index testing and social networking approaches. And as we speak, even under the ICTC, we are looking at risk assessment as a very important criteria for taking forward, you know, the chain of what happens once you reach the ICTC. The risk assessment happens up front. So obviously we are looking at understanding if somebody tests reactive to basically reach out and do an index testing approach. Maybe in our ART centers or perhaps across wherever in the projects, even in the present project, there is a Tal pharmacy. I did not really see too much of prevention visible in the presentation that was made today. It was more about how we have enhanced the pharmacy to look at providing services. The prevention that I saw there was PEP and PrEP, but maybe we can have STI, we can have index testing happening there as well to identify the risk and also to be able to reach out to more number of positives. And this is something we can quickly do in the program as well. Once like we look at, if the yield is 20% or 19%, it is definitely both of us are also in charges of the basic services division and not only TI. So we would be happy to go to any population and do the testing if we were to get a yield like that. And the last thing that I want to say is that in our program, we have a lot of terminology, a lot of jargon. We heard CBI. I didn't know what CBI was. So I think we need to simplify it. In our program, we are calling it partner testing or we are calling it spouse testing. And across different projects, we are calling them social network, respondent driven, EPOA, index testing. So maybe we just, in time to come, I'm not saying do it for the project, but at least once it comes into the program or into a more generic guideline, the terminology has to be far simpler and far easy for people to understand. So, you know, we don't want a counselor to say, I'm doing index testing and the other person is saying you're doing all wrong, I'm doing social network, and that's the way to go. So I think let's simplify this whole thing much more. And there is a lot of scope in the virtual, and it's good to see the amount of progress that has happened. But you know, I remember AS and DG guiding the grand challenges, and I think if Dr. Bitra is here, he will know that every month or so there used to be a meeting in FHI which he would personally attend and nurture the virtual space interventions. And as we sit here for prep, for self-testing, for virtual, for all these three, we have those white papers and the evidence is already there. So it's about how and where, in which select geographies and in which population groups are we going to take this forward within the program. So I think the discussions that happened here are going to help us to create that space to take this forward in the program wherever it is deemed appropriate. And I do again reiterate that we look at a 360-degree approach where we do not create further divisions of this is prevention, this is testing, treatment, and care. Rather, put everything, try and see what we can do across that continuum in each and every piece that we are looking at. So with that, I think we are at the end of this panel. We have taken more time than we should have, Aditya. So it's back to you. Sorry, questions. You're not allowing them?
Are
Okay,
you allowing
only two questions. Right. So one here, 1, 2, 3. 3 लोग. आ जाइए.
Ma'am, if you can request for brief and to the point questions and not comments necessarily.
No, I was hoping, I was waiting for this panel, in fact, because as a community influencer, I, especially in the, in the virtual space, there are certain things that are cropping up, which I feel can only be addressed through this platform. So this is really to you, Jalpa, and you, Vivek, sir. So, one of the things that's happening with being virtual is that people expect immediate and prompt solution and all your time and for you to be there, immediate responses, and that can sometimes be I mean, it's sometimes a question of boundary, but also we are getting suicidal cases, like cases of suicidal ideation. And what happens in those times is that, it is usually after office hours or it is on a weekend, it's late at night. And sometimes, we only know the area of this person and they may be using a different name. So in such sort of situations, we do find that sometimes we have a dearth of counselors who can step in and help. And this constant need for 24 hours, we are not as community activists prepared to handle the kind of mental health that's coming up with adolescents. So we need some kind of first aid training around that to be able to handle. Second thing is when we are looking at this platform, whether, again, when it comes to HIV or STI test, any kind of test, when you get the report, people are not bothered when the test is negative. But the minute you turn out to be positive, right, that is when the shame and guilt immediately sets in. And there is a time period between, like how Vivek sir said, you meet somebody face to face. And in that time, what a person ends up doing is going to the internet and going down a wormhole where you look at Google to be your doctor, and mostly YouTube. And what is happening is that in YouTube right now, we are not having material around health, which is from somebody who looks like me, who is talking, say if I'm HIV positive, is talking about my experience of being HIV over there, or being, maybe a person having herpes. I feel like YouTube is something that one must, like in such a program, really combine with, because YouTube is very actively looking for this kind of content. So do look at that platform. Thank you so much.
Thank you. Well noted.
Yeah. Hi, I'm Nikunj from Info. For example, if I'm a youth and MSM also, PLHIV also, and I'm into sex work also, for example. So if I will be walking in an intervention, like they will be considering me as a like in MSM only. So it should not be compared less boxes mein nahi hona chahiye. We should look into the intersectionality part also. The second, dissemination of the acts and the judgments also. For example, HIV/AIDS Acts 2017, the 377 judgment, NALSA judgment, or the Transgender Protection Bill, the basic counselors of the ICTC centers and the TI counselor, they should know about these acts and should disseminate to the communities as well. And the third and the last part, we should also, as we are talking about the virtual interventions, what about the semi-urban and the rural area people? They are also at a very high risk. For example, I'm in Nagpur. I'm people getting from Wardha, Bhandara, Gondia, and they are screen positive. And because they are not into social media also, but they are at high risk. So we should focus on the semi-urban and the rural area
Yeah.
community people. Also.
Thank you, Nikhil.
Yes, thanks.
You want to ask? Yeah.
No, I don't want to ask. I don't know if Alok Sir is here. I want to answer to his concluding question in the previous thing. Okay, my name is Dr. Zhongming. I'm from Mizoram. I'm working with OVC. We are working with HIV and affected. He was asking why the young people are not speaking out to their parents. How could we reach out to them or access to them? From my experience, from our experience in OVC, with the young people, why do they talk to their friends, not their parents, is trust. We have to make them trust us. And why do they don't talk to their parents is, if they talk to their parents, they will be judged. While if they talk to their friends, they will not be judged. So in our work, we keep talking about mental health and youth. If we are really serious about working with youth and their mental health, we have to earn their trust. Our field staff have to earn their trust. Once they earn their trust, only then they will come out with their own problem. Thank you.
Thank you. So, cheers for presenters, panel, and chair. Thank you.
So 1 second, please. I'll just request you to hold on if you don't mind. So we have a felicitation for the first session. Also, we were supposed to have one, but sir, the chair did not allow it. Okay, no. In this case, not at all. No, Dr. Shobhani, we just like a quick felicitation, please. So first of all, I'd request Mr. A. Vishwanathan to come and felicitate Dr. Shobhani Rajan, please, the chair. Thank you so much, Dr. Shobhani. Vishwa is the National M&E Manager with Accelerate. Dr. Anthony Reddy will felicitate Dr. Bhavani Singh. Thank you, Dr. Bhavani. Umesh Kanojia, the clinic manager with the Mitra Clinic in Thane, will felicitate Dr. Rajesh Rana. Thank you, Dr. Rajesh, for your guidance. Thank you. Miss Rachna from our technical specialist for transgender health in Accelerate will felicitate Mr. Vivek Anand, CEO Humsafar Trust. Thank you, Vivek ji. Again, thank you so much. आप नीचे कैसे आओगे? A big hand for Vivek ji also, please. Thank you. I'd request Baby Ria, a peer counselor from the AFHC in Imphal, to come and felicitate Dr. Rochna Mitra, please. And Dr. Alice, if you could come up and please felicitate Miss Abhina Ahir. Thank you, Abhina. Thank you, Dr. Rochna. Sana Macha from our Manipur Accelerate team, please would you come and felicitate Dr. Jalpa Thakkar and Bhavani from Hyderabad. Please could you felicitate Mr. Ajay. Thank you, Abhina. Thank you so much. Big hand for Jalpa. And Bhavani will felicitate Ajay. Thank you, Bhavani, and thank you, Ajay. All right, thank you, everyone. With this, we conclude the second technical session. We'll now begin our third technical session, which is on care support and treatment. First of all, I will invite the chairs and the co-chairs. So the chair for this session is Dr. A.K. Puri. Dr. A.K. Puri is DDG with NACO, presently also responsible for care support and treatment. Dr. Puri, if you could please take the dais. The co-chair for this session is Dr. Chinmay Das, who is ADG in NACO, also working on CST. On the panel, I'll request the panel members to join, please. The distinguished panel is Dr. Sai Prashad Bhavsar, who is Deputy Director with NACO, Dr. Pramod Devraj, who is Joint Director CST with Maharashtra SACS, Dr. Busarapu Ravi Kumar, who is Joint Director CST with Telangana SACS, Shri Sunil Goswami, who is a community representative from Gujarat, from the Gujarat Network of Positive People. I'd also request Dr. Rita Prasad from USAID, Program Specialist for CST, to join us in the panel. And I will invite the 4 presenters for this session. Dr. M.R. Parthasarthi, who is Deputy Director with Accelerate, based in Hyderabad. Dr. Manish Bamrotia, Technical Director for Accelerate. Dr. Jalpa Thakur, who is the Program Director, and Dr. Subhash Ghosh, the Project Lead. With that, I will hand over to the chair for the session. Sir, each of the presentations will be 15 minutes each, followed by 2 minutes inputs by the panelists, if possible, question and answer rounds with the audience, and then a summarization by the chair and the co-chair. So over to you, Dr. Puri. Thank you so much.
Thank you. So I don't think that you have left anything for me. Already you have decided time and other things also. So we have only to keep the time. So first session is regarding the technical assistance and the innovation to strengthen second and third 95 and self-verified adherence by Dr. Parthas, Deputy Director, Accelerate. Dr. Parthas.
Asmita. Yeah, thank you. Thank you, chairs, dignitaries and colleagues. In the next 15 minutes, let me take you through the journey of our technical assistance from Accelerate in our 7 cluster districts of Telangana and Maharashtra, where we do support in terms of prevention, testing, treatment, viral load suppression and retention, and so on. As mentioned by Sunil this morning and emphasized by our Dr. Shobini ma'am, our components work across and work in cohesion. So although I am presenting with respect to treatment component, at ART centers, we work for the first 95 as well in terms of prioritizing the clients for index testing, be it virally unsuppressed clients or clients of serodiscordant partners, so that now that's the reason why we are getting the yield or case detection in the range of 17% or more. And with respect to the second 95, we follow the patient-centric, peer-led technical assistance approach through our treatment buddies and program officers with respect to assistance in rapid ART initiation, meaning initiating ART within 7 days of diagnosis, then rapid response in terms of treatment interruption, meaning interrupting in the phase of MIS itself, and adherence support with special reference to self-verified adherence. I'll explain that, and treatment literacy and differentiated care service models and viral load counseling. With respect to third 95, we work on community mobilization or demand generation for viral load testing and follow-up of clients for enhanced adherence counseling and SACS, the State AIDS Clinical Control Panel, consultation panel. So we have the cross-cutting areas of capacity building, on-site mentoring, strengthening the data quality, very important part, as well as private sector engagement, which will be dealt by Dr. Manish little later. Accelerate started its journey in Telangana. Before that, just to make it precise, contextual, and for the interest of time, I'm restricting this data with Telangana, although we are also working in the similar intensity in Maharashtra as well. In Telangana, the Accelerate operation started during the COVID pandemic lockdown period. So the first need from the Telangana SACS was ensuring uninterrupted access or service delivery on ART to the clients, needy clients. So we leveraged the modifications made by NACO to facilitate the MMD and so on, relaxations in the MMD guidelines and community-based dispensation approaches. So it Accelerate started in quick consultation with Telangana SACS in terms of an operational plan of how to do it in the territory allotted to Accelerate. In fact, Telangana SACS engaged all the partners right from our Vihan, TIs and so on. But the territory is given to Accelerate. We had an operational plan with Telangana. Telangana SACS prepared a list of clients of who have to be delivered services through that. Based on that, we hired few community consultants who were possible to run through their own two-wheelers to deliver services. We facilitated the legal systems for that. And then we did the first job was to get consent from the clients for their house visit. As Sunil mentioned this morning, like we don't want to play with the areas of confidentiality. And those who consented, we delivered medicine either at their home or at the facility near their home and reporting back. That's another important documentation system we generated. So based on that, in the first wave of COVID, in the territories allotted to Telangana, allotted to Accelerate, we delivered drugs to around 40% of people who are alive on ART or currently on ART at that point in time. So in second wave, also we substituted or complemented the efforts of Telangana SACS in delivering ART medicine at the door, at the field level or community level dispensation rather. The most common challenge we found was incorrect contact information, and the reasons for opting out of multi-month dispensation was, centered around confidentiality, and they don't want to keep a lot of their pill bottles around. So we translated these messages into our actual intervention that I'm going to explain a little later while. And as the COVID impact was getting down, the very important challenge we found along with the Telangana SACS was the data quality. The key issue was the MLL and the master line list and monthly progress report were not talking to each other, and various different versions of MLL were followed. So we ensured to clean the data in close collaboration with the NACO, Telangana SACS, and other partners, including CHAI. We worked on the modalities of hand-holding workshops, hand-holding supportive supervision visits, transient HR support to ensure entry of backlog data, monthly validation and intensive review of the project. So at the end of the day, we found, so we did in cluster districts and other non-cluster districts. So we covered the entire state. So right from the variation of 11% to 170% variation, we made all the things almost 100%. They are now talking to each other. But now the challenge is to ensure and maintain this quality that Accelerate is providing a light touch support to all the ART centers in doing so. Then from January 2021 onwards, we started our actual field operations at the ART centers. So we delivered patient-centric and peer-led approach to strengthen the overall service delivery at the ART center. So we have program officers who ensure that NACO guidelines are followed at the ART center, both technical and operational. And we have treatment buddy who are again peers who do assisted linkage from a testing site to treatment site, peer-led counseling in terms of treatment education, ART education, follow-up education on viral load testing, ensuring demand generation, and also educating the clients on the importance of SASAP and enhanced adherence counseling. So the quick impact, the challenge here is, as I mentioned earlier, we do not have a clear denominator to set our baseline. So we are setting our year 1 and year 2 performance as how we are monitoring ourselves or how SACS monitors Accelerate. So the ART initiation, it was 93% in our first year of implementation, and it became 97% in second year. Rapid ART initiation again improved from 62% to 66%, and overall quarter-to-quarter retention as per the NACO scorecard, it increased from 83% to 92% in year 2, and so on. With respect to viral load, we had in the first year, we had the surge plant, which I'm going to explain. It was 69%, which came down slightly to 65% due to operational challenges in the availability of viral load in the state during that period of time. But now, thanks to Telangana SACS, every issues are sorted out. And now Telangana state proudly, we can claim like all the centers are linked to public ART centers. Private ART, the PPP model is now ruled out in the state of Telangana. And then viral suppression also we improved from 83% to 88% in the period of June 21 to July 22. Now I'll just let me give a quick glimpses on the successes of specific activities. So the first thing proudly we can say with respect to the USAID as well as CDC, where we worked closely with Share India partner, the viral load surge plan, which we did during January to June 2021, and which we continued later as well. The problem statement was only 29% of eligible clients have undergone viral load testing at the point of September 2020. So we instituted a plan along with the NACO and the SACS. We had a situation assessment, made an operational plan of collaboration and coordination, things made for supply chain management of all the commodities, then state and site level orientation and training of the ART officers as well as the laboratory staffs, strengthening the M&E system, data cleaning and data backup, and strengthening the review and proactive management in terms of wherever things are not working through proper way, we followed the way of a camp approach and so on. So with that, we ensured from 29% at the end of by May 2022, we have more than 70% of the people are now covered on the coverage has increased so on, as well as the viral suppression is now in the range of 76%. Then the test result utilization. Now that we have intensively increased the viral load coverage, the next problem is many people have now reported with the unsuppressed viral load. Earlier, the challenge was the SASAP. SASAP was constituted once or twice in a month, which do not have the capacity to handle this much of load of people who are presenting with unsuppressed viral load. So Accelerate again worked closely with the Gandhi COE Center of Excellence and Telangana SACS to constitute an operational plan for e-SASAP or electronic SASAP, where clients need not come. They can simply be referred through email, all the clinical and client records and clinical photographs to the Center of Excellence. So we have we developed a dedicated email ID for this to fast track the operation. And we also helped through a small human resource support in terms of listing of the clients periodically for the consultation of SASAP. So as a result, as an outcome, the turnaround time from the time of referral from ART center to getting the result to the ART center came less than 1 month. Earlier, it was in the range of 1 to 3 months. Now it is in the range of 2 to 4 weeks. Then at select ART centers, this is data for 3 ART centers, the SASAP referral was around 73% in our first year of operation. But now after constituting e-SASAP, it has become 10 times higher. 740 clients were referred, because now ART centers are confident, like, yes, we are getting response from SASAP. That's the key reason behind this. And during the demanding time of dolutegravir transition for Telangana SACS, Accelerate provided intensive technical support both through at the ART center level and heads, and also at the SASAP level, so that we did within a 2 months period, we helped the SASAP to do 573 consultations, so that in March 2021, the DTG coverage was in the range of 34%, which increased to 95% in the range of March 22. Now, almost all eligible clients are on DTG regimen right now. And this is again the rapid interruption in terms of the retention. So this is an example from Chest Hospital, where as per the latest NACO guideline, we follow the clients through phone within 48 hours of their due date. So now we can see 611 clients were reported MIS in October 2021, which is gradually coming down, which is only 354 in the range of March 2022, meaning like this plan works. So we learned from this, and we have advocated this with Telangana SACS, so that we are now planning to scale it up at the rest of the ART centers as well. The other key component of support which was required by Telangana SACS was in terms of coordination between HIV and TB component. So with all the technical support, with close collaboration with Central TB Division, as well as with NACP and other partners at the ground level, right from the ground level staffs of STS, I mean senior treatment supervisors, and DTOs, district TB officers, and city medical officers, and so on, we ensured single window TB services are now available in all ART centers in the cluster districts. Second thing, we oriented on the NICSHI platform, which is the data capture. Thank you, sir. The data management platform, we oriented all the ART staffs, and the NICSHI IDs are also shared from the TB department to our ART people, so that it is easy for both the ART staffs and TB staffs to monitor, and also for delivery of direct benefit transfers and so on. And we also ensured systematic documentation of TB preventive therapy as well as TB, so that now we have at least some good baseline data to show where are we in the last year and where are we going forward in the coming year. This figure, the table, which clearly demonstrates the result of our technical support in the Jan 20 to March 20 quarter. Almost 4 centers were not in the range of green with respect to 4 symptom screening. Now that in the Jan to March 22 quarter, all the centers are in green with respect to 4S screening. So that's the value of the technical assistance, especially through our ground staffs. Other quick activities, representation is like self-verified adherence, verbal autopsy that mentioned by Sunil this morning, and private sector coordination, it will be dealt by Manish later. So with self-verified adherence, it is nothing but a replica of 99 dots, which was formed under the Central TB division. So it started a couple of years ago. Now we are working through Accelerate at 49 ART centers across 17 states. So as on date, 7,043 clients are enrolled, and with the average adherence of 86%. The key point to mention here is like 98% of the people who are eligible for viral load and tested are suppressed among those clients who are enrolled in this model. And still this is work in progress. In our final round of dissemination, we'll be in a position to disseminate the entire data of SVA as well. And so as a way forward, as a final slide, we would like to engage continuously with ART centers to ensure data quality and reporting, which is the core for any of the program, especially with respect to data-driven PEPFAR programs. Second thing, sustained navigation of PLHIV to ensure like we keep on gaining the our whatever efforts done in terms of demand generation with respect to viral load testing, and proactive supply chain management, close collaboration with Plan India, collaboration with SACS and site level partners to ensure the viral load and other commodities are supplied appropriately to ensure we are progressing towards the third 90 in optimal way, and strengthening the capacity of ART centers, not only just the SASAP, also the DASAP with respect to the district level consultations, and using the community networks with the telecounseling as an ambitious plan for the next year in terms of optimizing our service delivery. Thank you very much.
Thank you, Dr. Partha. That was very crisp, and I think you touched upon many aspects of ART centers where we would obviously like to take things forward. So then we'd like to invite our next speaker. I think we are taking all questions in the end. So in the interest of time, I'll invite the next speaker, Dr. Manish Bamrotia. Dr. Manish is the technical director at Accelerate. He has vast experience of the field, starting ranging from ART centers till NACO as national consultant. And Manish, you're a painter, I didn't know. So we'd like to see your painting after this. So he is going to present on the use of verbal autopsy to determine the cause of death among PLHIV. Well, this is one area which the program actually wants to know more, because we have very little data on the death reported and the cause of death of these PLHIV. So Manish, over to you.
Thank you, ma'am. Good afternoon, everyone, respected chair, co-chair, panelists, and my friends in the audience. This presentation basically talks about verbal autopsy. So we all know that with successful rollout of ART program, we have significantly lowered down the AIDS-related deaths across our country. But however, it was a question that whatever reduced numbers who are unfortunately expiring even after registered at ART center, what is the reason? Are all HIV related, or some newer things are cropping up, or actually which OI, which symptoms? That kind of data we were looking for, and we supported NACO in doing this activity of verbal autopsy. So by definition, it is a method where a cause of death is ascertained based on interviewing a caregiver. So whoever was providing some care, we asked them set of questions that what happened when the disease, like what happened to him or her. And based on this, we try to link it to a cause of death. This method is accepted and validated and actually standardized by WHO. So we started with this two very important expected outcomes. So one is to guide program for planning interventions for preventable causes, as well as identified vulnerabilities, and to suggest a mechanism for death audits and reportings. So it was started in 2019 with support of USAID through project linkages, and later on field implementation was done by Project Accelerate starting from January 2020 to June 2021. The process flow was at the selected ART sites, which were 28, the line list was prepared by ART Center for all the deceased in the selected period. Calls were done by ART counselor to the caregiver whose numbers were available, and based on their availability, consent, and ability to contact, appointment was scheduled at a preferred time, though most of them preferred ART Center to be the site of appointment. Once the scheduled appointment comes, the trained VA interviewer from our side will go to ART Center and collects the information in this WHO verbal autopsy tool, which is very standardized. We used the 2016 version. Now even 2022 version is available. Later on, this data gets transcribed, and after this, it was coded based on the ICD-10 classification by a trained physician. So we did approximate, we did 1001 cases around these 24 SACS and 28 centers, and we decided to be the period as January 2019 to March 2020 when we started, and 87% of the cases were actually had a date of death between this period. However, we could get few cases where prior to this, and because exercise continued even after March 2020, some recent deaths also were captured because relatives actually came up to the ART centers. So these are quickly demographics. So we had a fair representation of all the age groups, but 40s being the most common, and gender wise male were more, the numbers were higher compared to females in the denominator are N. So coming back to cause of death. So after all this process, all these 1001 cases were identified or classified based on the ICD-10 cases. Just for the purpose of better understanding, we have clubbed them and grouped them under these causes. So first, the major, again, if you see HIV associated still remains the majority, and almost 77% had an HIV related opportunistic infection, which led to the mortality. But among these, majority, almost 51% were cases where there were symptoms, but we could not find a proper diagnosis in the report or the ART centers white card or with the reports available with the patient. So we have clubbed them. It was HIV associated OI. However, we could not get a proper diagnosis for them. This followed by 24% of HIV TB. Now, it is not that anyone who had TB are classified as TB deaths. These are based on the CD4 count, recent TB. These are being assessed as HIV TB. And a small percentage actually had, very few ART centers had a proper mechanism where they actually got a proper diagnosis in terms of maybe cryptococcal or toxoplasmosis or any such proper diagnosis we could. The other important thing is we could find the non-communicable diseases like heart diseases, hypertension, myocardial infarction, diabetes in almost 8%. And the most significant part is it's much earlier. We have seen people as young as 30 and PLHIV having NCDs and dying of NCDs. So heart attacks in 30s. And next very important thing is malignancy. And there were all the other things like injury, liver related, kidney related, and as well as self-harm like suicides also reported under these 1001. But however, when we look at the gender-wise data, the most significant part remains the malignancy. So even in this small cohort, we could see a higher percentage of malignancy among females and mostly attributed to the cervical and breast cancer. So this will come up in the further slides as well. So when we talk about undiagnosed OIs, 14% were actually respiratory, and learning was this could have been TB or could have been some other things possibility. CNS, again, CNS OIs has a high probability of being undiagnosed, 37% reporting headache, meningitis-like symptoms, but we could not find proper reports or supporting documents. However, most of them had a proper history of significant symptoms like, again, weight loss, fever, diarrhea, cough, these which we anyways are doing in 4S. We could also find most of these patients reporting, and maybe for a longer period of time. Similarly, TB also, we see a equivalent distribution among respiratory, central nervous system, as well as disseminated TB kind of thing. Coming back to cancers. So basically, there are two important things to note down here. Among males, lung and oral cancer remains the most important. However, for females, cervical cancer followed by breast and oral remains the most common cancers. And if you focus on the symptoms, cancer symptoms also mimics the symptoms of the advanced HIV disease. So it again says that you need to have more kind of capacity building, more tools, more screening specifically for cancers as well. We did try to have an association of duration of ART and which are the causes of death. So again, these are limited for 660 cases where we could find out these details. Though we have fair representation, but then maximum are patients where within the first year of ART initiation, again hinting towards that many, still a significant proportion of our patients come to ART center late in their presentation. However, you can clearly see when it comes to advanced disease or HIV associated OI, it is across all. So learning point, again, very important learning point. Advanced disease does not just limit to the new initiations or new registrations. You need to be vigilant across the care cascade, wherever, irrespective of ART duration, if patient complains of something, we need to suspect this. NCD definitely being more prevalent among patients who are on ART for larger, like higher number of ART, maybe due to kind of control over the HIV disease. There were some other findings as well. So there was a question like associated conditions. These may or may not be a direct cause of disease, but that cause of death, but they were present there. And most importantly, you can see 50% said they had TB. Almost 10% said they were diagnosed at blood pressure. 7% had a diagnosis of cancer. Yeah. Two other important things, which again is a important learning, was alcohol use and tobacco use. So among the male population that has been interviewed, the deceased, the respondent said that approximately 54% had a tobacco use history, while 58% had an alcohol. Though they do not have a direct correlation with cause of death, maybe tobacco has with cancers, but alcohol definitely affects the adherence and may have caused a poor response to HIV that we can further explore in the data. There are some important findings as place of deaths also. So we can see only 34% had a institutional deaths, wherein disease is dying at the hospital, and rest are either a home death or a on the way. However, the important point is that even those are non-institutional death, 84% reported that they took some care in an hospital in their final illness, which gives that it's not a completely blind area. There are people reaching out to hospital, and some data definitely sets in our indoor settings. And in case of institutional deaths, majority were in the government, but then patient had sought care at the private and other facilities as well. So major observation, I'll again summarize. The most common cause of death remains the HIV associated opportunistic infection. Majority among these lacks reports of diagnosis, which is a area of work. Among non-HIV related causes, malignancy and cardiovascular disease are the commonest. And if we can work on the risk factors, we may have some advances here. Malignancy is comparatively higher among females, specifically for cervical and breast cancer, again underlying the need of regular pap smear. Among males, oral and lung cancers were the commonest, again underlying the need for tobacco control activities if person is addicted to tobacco. And majority respondents reported non-institutionally deaths. However, there was some care sought at the institutes. So key recommendations of this activity remains that one, we need to develop a system to ensure that data between our indoors division and our ART center talks to each other. That could be the first one, because we have seen most of them have come in contact of the health system. Okay, they, even if not a death certificate, they will definitely have a last discharge card or some case report where you can see what OI was there. Second is we can think of developing short questionnaire or checklist for outreach staff. Whoever is coming to know that person has died can ask 10-15 questions and come to know that what could be the probable cause. That's how you can institutionalize it. One very important is strengthening advanced disease management, though it is in our guideline. We are awaiting rollout for some of the tests like TB-LAM and CRAG, but still one learning point could be there are symptoms which are talking about advanced disease. Till the time or till we are strengthening that laboratory, we can focus on symptomatic approaches like we are doing in TB for advanced, and we can actually save few more lives. Definitely capacity building on prophylaxis, diagnosis and management of opportunistic infections as well as non-communicable disease is need of the hour, which we have included in our recent technical guidelines, but needs to be further disseminated as well. So these are all. Thank you very much.
Thank you. So our next speaker is next. So, चलेगा कोई प्रॉब्लम? ठीक है फिर. Then Jalpa Thakkar is our next speaker. Initiative for the strengthening collaboration and engagement with private sector and private medical colleges. She'll be speaking on.
Thank you, sir. And thank you, Dr. Manish and Dr. Partha, for that very important findings, which gives us the platform to talk about very quickly. This time is going to be very short. One of the important aspects of strengthening our entire treatment program is the private sector engagement. Like Madam said, it's not just now treatment. It is actually about prevention, testing, and treatment. So why is the need, right? So we know that we have reached we have done a significant progress in terms of our 395s. However, we know that more than 80% of Indians do seek services in the healthcare program outside of the government facilities. But in our HIV program, especially in the ART program, we do have more than 90% of the PLHIV within our program, and hence there is a gap of 10 to 15% that we need to work with, that we need to report into the national program in order to actually understand our entire cascade. And there are various reasons why people or PLHIV still do prefer to go to the private sector for certain services. And as we heard from Dr. Partha and Dr. Manish's presentation, there is a few percentage that goes to the public sector, to the government ART, and then comes back to private. And then that cross-referral keeps happening. And that transition needs to be somewhere structured and smoothened out for better management of the particular case. We also see from the recent drug sales data that in Maharashtra, there is a huge, actually Maharashtra accounts to more than 84% of the PLHIV in the private sector are in Maharashtra. So we are working in Maharashtra and in Telangana, where we have about 30,000 PLHIV who are seeking care in the private sector in Maharashtra, and most of the districts are Pune, Mumbai, and Thane, including some others like Nagpur. And 2,300 patients approximately are seen to be in the private sector in Telangana. So we have done some efforts to reach this denominator in the private sector in these two states. So in terms of our objective, it's very simple. First thing is that we want to also see most of the practices in the private sector is right now not structured, is not necessarily following the national guidelines, right? And the private providers also look forward to have that support, to have that capacity within their practice. So one is to provide that support, especially for retention, for counseling, and for viral load management. Second is, there have been proven models from other programs like TB, where providing support through treatment buddies, treatment supporters, what do we call them, for counseling, for adherence, for LFU trackback can really help us understand the program in the private sector, and also eventually report these cases into the national program. Of course, build sustainable models within the ecosystem, because in the private sector, the work is very different. We go and we tell them that do A, B, C, D, that doesn't really work. So within the ecosystem of the private sector, and wherever the referrals from the provider to the lab to the chemist is happening, a model built around that would be really sustainable in future. So that was our aim while developing the model in the private sector. Of course, ensure reporting in the national database, and capacity building and technical assistance. So CMEs and trainings not only like it was aimed to bring that capacity, but also to bring the entire network of the private providers together, so that any cross referrals between private and public, between private and private, can be further strengthened. So what was our model really when we started working in Maharashtra and in Telangana was, we approached the doctor, and we have a personnel who we call as technical coordinator for private sector engagement. And they have this expertise from the pharma background. Specifically, they were medical representatives before, and now they're working with us in the program. And they know the language on how to talk business, on how to talk volumes with a private provider, and convince them to, you know, come to the platform where we can work together, specifically for improving the adherence and reporting. Then we have the cadre of treatment supporter, very similar to a combination of counselors and the ORWs, who helps the private provider, one, to bring in systems for case management and data management. What we saw when we went on the field was that none of the private providers, so to say, would really have any case management system, like we have the white cards or the MLL. None of that was existent. Most of that would be in a normal diary, and they would not even have you know, the history of whom to call back, or who's in LFU, or when is the viral load or a CD4 due. So that was another support that was needed to be provided through this cadre of treatment supporter. And what we really did through them is, one, we introduced a case management sheet or a case registration sheet, something similar to you know, the white card, but in a very succinct way. And we also introduced a line list. Right now it's in the Excel format. We are trying to make it more digitized and simpler so that it's sustainable. And all of that would maintain the whatever minimal possible data of the PLHIV coming to the private clinic, so that it's easier to track, it's easier to provide counseling, adherence, support for testing as the patient goes ahead with the treatment. And the network with the private laboratories and chemists, I think we spoke about it earlier as well. One of the things that we found out, we also did a survey before starting this program with the private providers, is having subsidized, and we heard that in the TAL model as well, having subsidized services, especially in testing and in treatment both, would be really beneficial. Because once the PLHIV starts taking treatment in the private sector, paying 2,000, 1,500, 2,500, depending upon the regimen, is not easy every month. So eventually there is fatigue. Eventually there is you know, interruption in the treatment. So a subsidized network is really important to build. And we were able to engage with a few laboratories and the chemist, especially TAL pharmacy, to provide that subsidized services. So what really went on the field to actually, the end outcome here was to provide adherence and counseling support to the PLHIV, maintain the you know, the data at the private clinic, and report those quarterly report that Dr. Manish showed us early on in the TAL Plus presentation, the format that NACO has given for quarterly reporting. So all of these steps were important to actually reach that end outcome. So we started with mapping and listing of the private providers. Now, what were the sources of this? There were many sources, but some of the important sources were chemist surveillance, prescription audits, snowballing. After we engaged with a few high burden providers, we started asking them about their network. So that led us to a whole list of about 600 providers. And then those providers, through the technical coordinators, were surveyed to actually understand who has the burden or the load of PLHIV and who practices literally the HIV medicine. Then third was, yes, the source verification. So there were a lot of processes involved in prioritizing the providers. And then once we prioritized, the technical coordinators actually went with the entire list of services that Accelerate could support with to improve the treatment outcomes in the PLHIV in the private sector. And then finally conducted MOUs, meetings with SACS, CMEs, and started the case management at the private clinic. So the treatment supporter that we saw earlier would actually visit the private provider at least twice a week, because one treatment supporter will have more than one private provider to manage. So they will visit once or twice in a week to call the patient, to provide counseling, to provide adherence, to track back the LFUs, and to maintain the case sheets and the MLL in the private sector. So in terms of progress, like I said, we have about 485 providers mapped, 275 of them were surveyed. We saw that 133 of them were interested in working with Accelerate after we showed them the services, which included all of these things that I said. And then 80 actually ended up both in Telangana and Maharashtra together, signing MOUs with us. And then out of that, we again prioritized because we have to optimize the treatment supporter service that we provide. So 43 of those providers actually had more than 25 PLHIV alive on treatment with them at that point in time. Although the scope was much more, because during COVID, there were a lot of LFUs or a lot of patients went without medicine, or most of them were actually linked to the ERT center. And now, even though we have MOUs with 43, but without MOUs also, we have about 56 providers in both the states who have started activities. When I say started, they've started reporting the cases in the national database, and they've also maintained a case sheet and MLL at their own clinics. And 34 of them are now regularly providing the quarterly reports to both the SACS on the periodic basis. In terms of the support provided by the treatment supporters in one-to-one counseling at the clinic to the PLHIV seeking treatment in the private sector would be, out of the providers that we are working with, we see that about 2,445 PLHIV, we have a line list of these many PLHIV in the private sector. So whatever data is getting reported in the national reporting systems is now validated through the line list available at the private sector, which was earlier never available. About 1,000 of them have actually received one-to-one counseling and retention and follow-up support from the treatment supporters. 15 of them, we were able to kind of provide subsidized medications through pharmacies attached. We have 13 laboratories right now whom we have MOUs with and who provide subsidized all the baseline as well as follow-up testing. And one of the very important achievements here is that earlier when we started about a year and a half back, there was no data on viral load, almost nil, like hardly 2-3 patients. But now we have, through the efforts, more than 2,000 patients underwent actually viral load testing, and more than 90% are virally suppressed. But the efforts are still on because of the confidentiality and the socioeconomic cadre of people who come to the private sector. It's very difficult to penetrate and to talk to them one-to-one. But this is how we are moving forward and hope to achieve a lot more in the coming days. So in terms of way forward, I think there are certain cities, there are certain districts where the PLHIV burden in the private sector is very high. And so a heavy model with a treatment supporter and a technical coordinator would really work. Places where the PLHIV load is low, we could have a light model with one human resource supporting all the activities, actually, which is already happening through other partner agencies like Alliance. A comprehensive package of services. So if our end outcome or the objective is reporting, entering a private clinic and saying just report is not sustainable. So providing the entire comprehensive services for the PLHIV, other prevention services like HIV self-testing, PrEP, and counseling is also very important to keep that provider engaged and scale it up further. And finally, leveraging support from cadres like treatment supporter is also very important, because this is one service during our survey that most of the providers said would be interested in working with us for. Like, just because there is a specific person at the clinic providing counseling and reminder for the refill support to the PLHIV. So with that, I would like to end my presentation. Thank you, ma'am.
Thank you, Jalpa. That was well on time. I am told that Dr. Pramod Devraj and Sunil have to catch a flight. You want to go right now? Give your comments right now. Okay, so in the interest of time, we'll take the comments of these two panelists right now before we go to Dr. Subhash.
Thank you, sir. Thank you, madam. Congratulations to the Accelerate team. I think out of the today's 9 initiatives that have been highlighted, so it is a pleasure that I've been witness to all these 9 initiatives. So the first aspect that was highlighted in Partha sir's presentation was desk review of whatever is available. I think with YRG placed in SACS, I'm just trying to give you our aspect of what has been done in Maharashtra. So the desk review with YRG team, having discussions, deliberations, things have come out in a right way in perspective of what field staff is right now saying. This is the first time, so I've been looking into the partner coordination activity for more than 6 weeks. Whatever HR support that was being provided, so even if it went away, there was no such noise. But right now, this is for the first time that the resources that have been put by YRG to Project Accelerate. When we started this, because of some issues with budget, some districts, the staff was being removed. That was the time when our centers started asking me, sir, why are we this help? And especially in the context of COVID, this was a big help that was being provided by Project Accelerate. Now, how do, as a state person, I look? Now, if we look into the aspect that one size does not fit all, it was a HR support that was being provided to the ART center based on their needs. I was not asking the help. The centers were demanding. So be it viral load testing, be it medicine supply issue, be it LFU tracking, list tracking, or monitoring the adherence of the patients. So based on the scorecard that we had, the NACO had developed, wherever there was gap, the centers identified those issues and they had given the task to this supportive staff, be it treatment buddy, be it the data entry operator. So that was a kind of a collaboration that the project has been in supporting SACS right now. Although many things are discussed here. So in a nutshell, if I try and sum up, when the project ends, how do we look into these aspects of scaling up, multitasking of the existing staff and converting? Because right now, our counselors as such are in such, be it the NGO staff, be it our counselors. So in the aspect of just discussing about index testing, too much data entry, too many newer initiatives being pulled into the program. So that is where I think the symposium or the thinkers here need to really take it forward as to how it gets incorporated into the program. It should not be an activity where an initiative was taken and it just vanishes off when the project ends. So Alok Saxena sir in the morning had also said that here is the right time where we also need to think upon NCDs. Although it is a part of the larger health system, what will be the role of SACS staff? What will be the role of the supporting agency? And how do we really take it up? Because data is here. If we just look into the verbal autopsy data, 7% deaths have occurred because of hypertension, another 6% accounted for diabetes. Whatever data the state has, it's around 9% that we have out of the existing data. The 9% are having hypertension. So in a nutshell, if we think of how do we comprehensively build up a package be it what all ideologies that right now NACO is having. Uh, for example, Madam Shobini Madam was speaking about Sampurna Suraksha. This is a good platform where within our program there is a scope where services could be integrated, but it should not be in bits and pieces. That is what, from field perspective, I would like to place it in front of the panel and the dignitaries. So thank you for giving me an opportunity, and really I'd like to apologize because of shortage of time. I need to hurry because I have flight to catch. Thank you, Project Accelerate and the team, and the wonderful presentations that have been given by the four members today.
The next speaker on the panel is Sunil. Next speaker is Sunil.
थैंक यू कि एक अपॉर्चुनिटी हमको जो दिया, जैसे सभी इतने हमारे जो प्रोग्राम चल रहे हैं, तो सबसे ज्यादा मैंने जो पीपीटी में हमने जो देखा, जो डेट है हमारे लिए, तो एक डेटा नहीं है। जैसे मैं मेरी बात करूं, 2009 में मेरा डायग्नोस हुआ और 11 में ट्रीटमेंट मेरी शुरू हुई। तो मैंने पहले मुझे नहीं पता था कि HIV क्या है, ART क्या है, ICTC क्या है। एक सिंगल टेस्ट हुआ, उसके बाद कंफर्मेशन हुआ, उसके बाद ART स्टार्ट किया, उसके बाद जाके जो डिस्ट्रिक्ट लेवल नेटवर्क है वहाँ मैंने कैसे पीयर टू पीयर जो सपोर्ट मिलता है उसके बारे में मैंने देखा, सोचा। 2 साल तक मैंने मेरे घर पर या किसी को नहीं बताया था कि आई एम HIV पॉजिटिव। तो मुझे लग रहा है कि 2009 से पहले 2005 से ART सेंटर पूरे, मैं गुजरात की बात करूँ तो 1 या 2 सेंटर थे। 9 में उससे ज़्यादा हो गया, डिस्ट्रिक्ट लेवल तक सेंटर थे, ब्लॉक लेवल तक ART लिंक ART सेंटर था। तो हमारे इतने सारे प्रोग्राम चल रहे हैं, नाको है, हमारे एड्स कंट्रोल सोसाइटी है, हमारे विहान प्रोग्राम है, हमारा स्टेट लेवल नेटवर्क है। तो हम कभी ये नहीं देखते कि ये हमारा डेटा है, हमारे लिए एक जिंदगी है। हम सभी को साथ में मिलकर इसको कैसे बढ़ाना है, खास करके हम जो देखें कि ट्रीटमेंट लिटरेसी है, उस पे सबसे ज्यादा फोकस करना पड़ेगा कि क्यों दवाई खा रहे हैं, क्यों हमारा वायरल लोड होना चाहिए, क्यों हमारा वायरल लोड सप्रेस होना चाहिए। 95 गोल है, वो हम सभी को पता है। जो कॉमन HIV पॉजिटिव है, न्यू डायग्नोस है, उसको नहीं पता कि ये HIV का क्या है, वो कैसे शरीर पर हमारे इफेक्ट करता है। तो मेरी एक रिक्वेस्ट है कि जो हमारे यूथ, मैं गुजरात के यूथ को रिप्रेजेंट करता हूँ, तो यूथ को NCPI का जो यूथ है हमारे साथ, एक 100 से ज्यादा यूथ हमारे साथ अभी जुड़े हैं। तो उसका एक कैपेसिटी बिल्ड हो, उसकी नीड है, उसका हेल्थ का है, उसका एजुकेशन का है, उसका मैरिज का है, उसको कैसे आगे बढ़ने का है, वो भी उसका नीड है। और कैसे ट्रीटमेंट लिटरेसी का उसको नॉलेज बढ़े, कैसे उसको हम समझाए, उससे वो दूसरे को कैसे समझाए। अभी मेरा जो जितना भी फ्रेंड है, हमारे फैमिली है, उस सबको पता है कि HIV है तो जिंदगी खत्म नहीं हुए, उसका ट्रीटमेंट है। आप ART पर जाओ, रेगुलर दवाई लो तो कुछ नहीं होगा। जैसे हम सभी को कभी फीवर हो जाता है तो डॉक्टर लिख देता है 10 दिन का गोली, तो हम फीवर कंप्लीट हो जाता है तो हम 10 दिन का गोली नहीं लेते। ये लाइफ लॉन्ग तक के लिए हमको दवाई लेनी है। तो उसको काउंसलिंग की जरूरत है, मेंटल हेल्थ की जरूरत है। तो हमारे जितने भी प्रोग्राम है, तो कहीं ना कहीं हम गोल तो अचीव करना ही है हम सभी को साथ में मिलकर। पर हमारी जो जितने भी हमारे HIV पॉजिटिव लोग हैं, हर एक को ट्रीटमेंट लिटरेसी उसको मिले, उसको नॉलेज मिले HIV के बारे में। जितनी भी सर्विस है, क्वालिटी ऑफ उसकी लाइफ बने, क्वालिटी ऑफ सर्विस मिले, तो हम सभी डेफिनेटली जो HIV का गोल है 2030 तक का, तो हम डेफिनेटली एलिमिनेशन तक जाएंगे। थैंक यू।
Thank you, Sunil ji. आपकी flight है? Okay, thank you very much. Okay, so coming back to where we left, so I'll call Subhash Ghosh for the next presentation. That's on learning from OVC program on better treatment outcomes for children and adolescents living with HIV. So,
yeah, ma'am, I have one request
post this presentation, I would like to invite our AFSC team members to share their experiences for a few minutes.
Just keep your presentation
yeah.
short, maybe. In the
Yeah,
interest of
thank you.
time.
Thank you. So this OBC program, we actually inherited from linkages in the year of 2019, and where the focus was children of key population. So if you look at OBC program, it actually touches all components of NACO. It touches the prevention component run by TI. It touches the BSD for HIV testing and screening of children. It touches the CST division. So it's a cross-cutting area. So when we look at also in the field, we look at from that comprehensive lens. So in terms of our OBC program currently, since April 2019, we have changes in population. We started with children of KP, then we started working with CLHIV. Now we work with children and adolescents living with HIV 0 to 17 years and affected children. So mostly single orphan and double orphan and their caregivers. So if we look at the package of services, it's a comprehensive package of services. It includes HIV services, which relates to risk assessment, facilitating testing with consent, as well as linking them to treatment. Then general health services, mostly in collaboration with NHM or private provider, and then other services, which includes life skill education. So our field staff, child care facilitators are trained on life skill modules, which were also developed through NACO and USAID collaboration, and then the parental education and literacy. So our goal is to make all these families healthy, educated, safe, and stable. When we say stable means they are socio-economically stable. In terms of our beneficiaries, by September 2022, we have reached about 42,687 beneficiaries altogether. Out of them, about 70% are children, 0 to 17 years, both infected and affected. 78% are adolescent. Like in my other presentation, I was highlighting why you need to have a lot more focus on adolescent specific services. And 95% of these 29,000, based on their risk or biological parent, they are eligible for testing, and 92% know their result. So I must thank all the SACS, DAPCHU, and my team members facilitating this testing. This was a really, huge task for all of us, taking them to the ICTC, getting them tested, counseling their parents, taking their consent was a real challenge for all of us. In terms of our profile of beneficiaries, about 71% are single or double orphan from about 29,000 children, and 40% are also CLHIV having single or double orphan. And 36% of them had a elderly caregiver. When I say elderly means they are 60 plus. When I say very young means they are less than 18 years. So somebody less than 18 years is taking care of another sibling who is also CLHIV. And 70% have HIV positive parent and caregiver. This really helps us in doing a combination of work. So suppose a parent is also LFU and we are reaching to the same family. So we provide counseling and guidance to the parents so that they can also continue on treatment. So this also brings us that we can really work together with Sathi, Bihan, especially PPTCT partner and the partners who are working on ground to focus more family-centric approach. These are some of the quotes I have already discussed in my AFSC presentation. Now let us look at the occupation profile. So about 8% of our caregivers are unemployed. However, among 20,000 family, 43% didn't have consistent source of income during last 6 months. So COVID was not there, but there were challenges in terms of having a consistent income. So what we prioritize that antiretroviral is important, but then social protection services are equally important for these families. So about 2,250 who require ration card. So we have been able to support about 26% of them. Similarly, about 1,000 require Aadhaar card. We have been able to, support 38%. 1,553 require birth certificate. We have been able to provide support for 28%. But the challenge with birth certificate, as per Government of India Birth and Registration Act, that if somebody has not received their birth certificate, they have to pay a fine, which is often very difficult for our children to support. Thanks to Mizoram SACS and NHM, so their NHM has agreed to bear this cost from their funding. So I would like to request NACO if they can also, have a Government of India order for this process. Now, how we do this is very challenging process. So we, work with the parents, caregivers, both in facility and community. We obtain consent and then we enroll all these children. As we know, there is a strict data sharing policy under our program. So it is often very difficult to get those information, but there are referral processes among our ART centers and partners through which we have been able to register all these children. We assess their vulnerability, treatment and viral load service need, nutrition need, including weight monitoring. We also have a very good program called Mothers MUAC program. So where mothers are trained how to take measure using MUAC tape. And in remote regions where we cannot travel frequently, where mothers help us to in weight monitoring. So if the household doesn't qualify for, or they do not give consent, we do not enroll them. Once we enroll them, we develop a case plan, because it is all the services, the needs. If a birth certificate has to be there, the caregiver has to visit to the office, has to provide relevant document. So it's a participatory process where we help the caregivers to prepare the case plan to achieve all our goals of healthy, educated, safe and stable. So this is our cascade till September 2022. About 8,382 CLHIV are there. And almost all of them are on ART. And based on last 12 months, 4,547 have tested and their results are received. 81% are virally suppressed. When we started OBC program in 2019, among children, it was 54%. I think thanks to all the partners, SACS, ART centers for, guiding us in achieving this 81%. And also among these children who are eligible for DTG, we have put about 74% of this CLHIV on DTG. About 6,200 children are on DTG. Those who have completed 6 months, we have very good viral suppression among them. We also work with Bihan, SACS and ART Center to improve LFU tracking. So there are about 997 LFU in our 33 district, and 765 have been tracked back, out of which 377 we have reinitiated on treatment. So this is the process. Once somebody is initiated on treatment, we focus 15 days intensive, monitoring, basically OI and side effect, because we found that is the first trigger point where, children discontinue their medicines, or, the parents take them to another medicine, maybe an alternative medicine, maybe Ayurveda, because they also concerned about the health of the child. Then 4A screening and IPT support, regular weight monitoring, nutrition support. So a lot of our nutrition support is through individual donors. We almost raise 2 lakhs per month worth of donation to provide nutrition to all our children across 33 districts. Then adherence monitoring through different processes, and then bi-monthly health checkup, including RBSK health checkup. So I must also thank the RBSK team who plan very meticulously. Like if there is a child who is not coming to the RBSK, whenever there is a field-based camp, how we will coordinate and ensure those children are, undergone RBSK. Why it is important? I am saying that 12% of our children who have undergone, RBSK health checkup were found having neurocognitive developmental delays. So this is a very important service we provide to our children. And then quarterly once ART center visit. So I have almost completed these points. I will go to the next. So what are the tools our field staff use? So our field staff are trained on how to look at OI and side effects monitoring, HIV risk assessment among children, barrier assessment among virally unsuppressed, so that they can plan, different approaches for individual cases, screening of common elements, especially dental, eye, ear, and skin, so that we can link them to the ART center. And then daily life of children of caregivers, because what we found that a lot of children, when going to school, how we will manage the home visits, whether Saturdays or Sundays, and then how we will ensure that they are taking proper medicine. If the mother is also working, so how we will ensure that the adherence is maintained. So daily life, understanding the daily life of the child and caregiver, providing guidance to the family is also critical for us. These are some of the job aids available in Telugu, Mizo language, Meitei in Manipuri, and then Hindi and Marathi. So these job aids really help our child care facilitator to plan their work with the caregivers. I will go to the next. Yes, ART center is very critical to our success, because they really help us to fine tune the different models that we are working, especially weight related data in dosing, because a lot of the time it is the proxy caregiver comes to the ART center to pick up the pills on behalf of the children. The children is there in the home or in the school, but somebody comes and picks up the pill for the child. So how we can use the weight data from the community, update in the ART center, so that the dosing becomes better, because dosing is very important for pediatric case management. Then MMD and family centered approach. Family centered approach, I must thank many of our ART center has done this excellent job of clubbing the dates of pediatric and parent ART dates. Because earlier what used to happen, parent is coming on 5th, child has to come on 15th. So the parent has to come at least 2 times in a month to collect the medicines. So what we did, we made it a family-centered approach, so that all these dates are clubbed, their regimens are fine-tuned, so that they can collect medicine on one day. Then joint home visit. In critical cases, a lot of our ART counselors, they make joint home visits, and they participate in mental health clinics. We run one of the community ART refill groups, thanks to ITech and Manipur SACS. Then home collection of viral load sample. We also run a helpline in child-friendly ART center in Imphal. This is a child-friendly center in Aizawl. It's a community refill site where you can see the happy faces, because the mothers, they say, we cannot come to the ART refill site where we will leave our children. So we thought we will start in Aizawl. And now, PWNM, our partner there, they've also raised some funding. We also run 4 other child-friendly sites: Tirupati in Andhra Pradesh, Imphal in Manipur, and then Thane and Pune. All these are run in ART center. During COVID also, we did certain work. So we trained all 1097 and 104 helpline counselors. Because what we found, a lot of our parents said, if I call 1097, they are not sure about the COVID vaccination among children. They are not sure how to manage COVID and HIV cases. So we trained in a partnership with Pyramid Foundation. We also vaccinated a lot of our adolescents through the Government of India program, so that we can protect them from COVID. These are the other contributions. So supply of sanitary pads and iron and folic acid from the adolescent health program under Government of India. We have trained our field staff by the mental health program of NHM, and also close collaboration with CDC treatment and viral load partner in AP and in Northeast states. So these are some of the potential learning. I think there is a need for child-friendly communication and counseling skills for our ART center staff, so that the parents will motivate to bring their children. children will be motivated to speak, and I think the quality of care can be improved. Similarly, weight monitoring, I think we can really update our white cards even across the country, quarterly once, their weight. Similarly, the age mentioned in the white card pertains to very old. If a child is 11 years, the date of birth or some age is written very long back. The age is never validated. So we can really work on those so that the quality of dosing can be improved. Similarly, adherence and retention support are very critical. So as we know, proxy caregiver coming, we do not know whether the child is taking medicine. And we also found a very strange behavior with our caregiver, because we are focusing on adherence. They will hide the pills, extra pills. They know now we are asking the number of pills, number of days spent. So they will, hide the extra pills. They will keep only the pills which is, pertains to the number of days. So whenever we visit, we'll find everything is good. But the child is having OI, child is having, other health problems. So how we start, having a different way of approaching adherence monitoring instead of doing only pill count. So we use motivational interviewing skills, open-ended question, so that, we do not talk about pill count. It is more about talking about the daily life. How is the child doing in school? How is the child doing in studies? And then, we come to know there is absenteeism in school. We come to know that the child is taking a cough syrup. The child is taking, fever medicine. So these are the ways we can really. The last request to NACO and to my other colleagues, if we can think of dry blood spot based viral load, at least for less than 10 years children, because where we find the viral load testing is very low. Parents are not motivated because of disclosure issue. They don't want to bring their children.
I'm sorry, your
Thank
time
you.
is over. Please wrap up.
Thank you. And this is my last slide. These are thank you messages in different languages from our children to all of us. I would like to, with your permission, like to invite our AFSC staffs to come and share their experiences in 1 or 2 minutes. Thank you.
Dr. Subhash. Dr. Subhash, please come, please join us. Yes, you have eaten away their time, actually. Please, आप आइए बोलिए. थोड़ा सा माइक पास करिए.
Oh my. Hi everyone, my name is Valentina and I'm a peer counselor of Manipur AFAC Imphal. Hi everyone, good afternoon, good evening. I'm also working as a peer counselor for Imphal AFAC. I'm Ornella. Today we're going to share about our life experience. The issues that we face. Yeah, as an adolescent and a youth living with HIV. Yeah. We both are like HIV positive, and we work for the adolescents only, and when we are like in the youth days, we are During facing my lots of adolescence days, we face lots of problem, going to the RT center is also a problem. Like people were thinking as a female sex worker because we are holding the green card and standing in the RT center. People start spreading rumors about us, like, oh, they are the sex workers. They they got HIV positive because of the we're doing professions. Yeah. So because of this, we face lots of problem in the schools also. even like I think I am in the 7th or 8th standard. I think in the like in I think the subject is English. So in that there is a one lesson about HIV and AIDS. So like when teachers started explaining about that topic, I feel like self discriminations about myself. If my friends came to know about my status and what they'll think about me, like my friends will kick out from their friend circles like that and all. Like so I was like in a panic to attend the class. Also, I can't even concentrate in the class like that. So we face many lots of problems like going like if I was working in Delhi in a call center for like 3 years. So I used to stop taking my ART pills because like if I'm taking the pills and going to the office, then people will start thinking me as she's using some drugs and coming to the office. And like it's not like that, but because of the efavirenz only, I got hallucinations. So I stopped eating the medicines and I threw the pills away. I never eat that pills for 3 years like that. And then my health condition was very weak, and then my hemoglobin was very low. Like when I came back to the Manipur, doctor was scolding me very badly because I stopped the medicines. So these kinds of problems, I faced lots of problems. Like even I committed to suicide also. I had break operations because I have committed suicide. Like I had lots of trauma. Like after my father passed away, my these grandparents were yeah. Yeah, she did so well. It's okay. I will continue on sharing my story now. It's okay. I'm with her. I'm It's so brave to stand in front of so many people and share your story. No, she's just like reminding us.
And you are now continuing medicine, helping others.
Yes, yes, that's what.
That's a big thing.
Yeah, I'll also share my story now. Like, I came to know about my status when I was in class 10. So like, when I didn't know about my status, like before I know my status, my mom and dad, they used to take me everywhere, like for training for HIV and all, since they were also working for NGOs about HIV. Yeah, but yeah, I knew everything about HIV that time, but like still, I didn't know that I was also infected with HIV. And I started my treatment when I was in the first year of my college in Bangalore. I started my first ART in St. Joe's Hospital. So what happened was, when I started taking my ART, like how she mentioned, I started having hallucinations. Like I was just laying down, and what happened was I was in a roller coaster. I thought like I thought if I was going insane, like I don't know anything about mental health at all. Like it's not like these days like we prioritize this mental health and all. Like we don't even like even if we are depressed also, we'll just like we are sad and all. And while hallucinating and all, and it led me into insomnia. I will like till now I still haven't can't sleep properly because I was afraid to sleep that I will have this same hallucinations again. And while like I have to be independent while living alone, like studying in another state outside of my home, I have to be independent. So what happened was I have to go and pick up my old bill from the hospital. And like as everyone know that every college has this attendance na, 75%. I have to attend that also, plus I have to go and get my own bill. So like it's like they try to like help me out with like setting my time on my holiday or my half holiday, but still like the PG that I stayed and the hospital was very far. Like it's just an inconvenience for me while traveling. Uh, the, and another issues was that I was staying at the PG with my friends. So like I had the disclosure. I have self-acceptance issues plus like self-stigma. I can't even tell my friends like I have this HIV. Like I can't even take the pills in front of them. Like the even the pill bottle was like in this MWay kind of bottle, like vitamins type. My mom will suggest me to put it there, but still my friends will ask, na, Ornella, why are you taking so many vitamins every day? Like, you're already taking for 1 year, like they'll ask, obviously. So like, I stopped taking in front of them, and then I stopped for around like 2 years, and then after that, I have this self-acceptance issue. Like, I started to rebel. Like, I used to think like my dad was the one who took the drugs, but why I am the one that I have to suffer? So like I used to think like, why should I take the drug? Let's just let it be. I'll just die like that. I used to think, and then while getting into relationships and all, I started feeling inferior. Like I will treat my boyfriend or my partner up there like a god because I'm HIV positive and he's dating me. Like he's doing me such a good favor, no? Just like giving me a crown, like he's dating me. So like we started to get into like abusive relationship, like physical abuse, emotional, plus mentally abuse. Even like sometimes like when we fight, yeah, he even hit me sometimes once. So like we face that like we have this inferior like somehow feel always small because we have this uh virus inside our body, like with our friends plus with our partners and all. And then
Thank you. Thanks a lot.
And lastly, what we want to say is that like NACO has taken up many programs like but there's no specific prevention and treatment for the children living with HIV or adolescents living with HIV. So we want NACO to discuss about this platform to be a specific platform like with the adults also. Yeah, we want like actually we are the one who face the problem. Yeah. So like we want to be the one who wants to like who has to represent it. Yeah. Because we know ourselves more than other knows us. Because we are the one who go through the problems, issues. Thank you. Thank you everyone.
So I must thank both of them and Ria. You know, it was a challenging time when we started AFSC. We were not sure whether we will find a person who is part of the group, who is of this similar age or same, a language they speak. So it was a difficult, and they took this challenge. They were also studying in colleges. They spare time for us, and then they started. And it was a COVID time, but they really took all these challenges to bring other adolescents to make these music class, thangta classes happening in the AFSC. Thank you very much.
Thank you. Now I invite all the panelists except the speakers to speak for 1 or 2 minutes. Please comment for 2 minutes.
Good evening, sir. Thanks to all given this opportunity to participate in this occasion today. And also special thanks to Dr. Alok Saxena and with the support of Accelerate NGO organization. Today itself, then inauguration felicitation by Help Desk Center for Transgenders at Karimnagar. It comes under Telangana district. And this session, what they briefed us about treatment protocol, about what's the regarding about adherence and support to private medical colleges and private hospitals, and verbal advocacy regarding who are dying with HIV. And last, the second and third, the intervention also, they briefed us. And finally, they very much emphasized about adherence as well as the treatment protocol support to follow. Okay, thank you.
Thank you, sir. I think we had excellent presentation. I think to sum up all the learning and to take from this, it is a very difficult task. I will still try to do some justice to it. I think we have got a rich experience of working in adherence, second 95 and 35, second and third 95. I think to just begin with the Partha, I think excellent presentation. I want to really congratulate him and his team. We know that Telangana was a new state for us. We went there were a lot of administrative changes which were happening, and I think the leadership which he has provided, working very closely in collaboration with the state and also CDC partner, a lot of good, I think he has shown, I think with data, like, you see the detention rate, I think, though you said that baseline is very difficult for us to quote, from 68 to 92%. So this is, I think, a good example of what is the close leadership and the TA which the team has provided. I also wanted to, like, highlight one of the work, I think that was the viral surge, because we know, like, when initially you went there, the viral load coverage itself was very low. So the team worked very closely with, I think, CDC is our viral load partner along with the state, and they used to have all these monthly meetings, and a lot of coordination happened. So we can actually see, like, when partners come together and they work with the state, not only that viral load coverage improved, it's also the viral load suppression which is quoted is 88%. So I think these are some good examples where, like, we can look at how we can collaborate at state level and work together as a partner. Also, I think if you look at the differentiated delivery models, COVID helped us to actually fast forward into multi-month dispensation, and all kudos to NACO. I think we actually stood up and saw at that time that multi-month dispensation happened. And it led to thinking of a lot of different models, like I think, community-based models and lot of delivery mechanisms which innovated, and which we can actually think of how we can move forward with that. In terms of adherence mechanism, like, we still think, what is that adherence thing which we are talking about? Because there are so many components to adherence. It's not so easy. We are there in this space for a long time, but we still see that we struggle with the adherence. So there are psychosocial component. It is also person-centric, because the approach which we will use for children for behavioral intervention or psychosocial may not be same for adolescents or with the women. So I think, or with the key population. So I think we need to think a lot here. And some of the good examples which they have shown with OVC, with the adolescent-friendly health clinic, I think we need to look at each one of it and look at the package of services which was provided under the project. Be it under OVC, I think lot of learning which Subhash has been sharing from there was a lot of component of psychosocial. I think he talked about step-up counseling. They talked about integrating PHQ-9 into entire that screening tool, and look at, mental health right from the beginning, and then incorporate component of psychosocial support into it. I think behavior intervention is something which we need to look into it, because we all know, like, so much of behavioral interventions goes into our adherence mechanism, and behavioral nudges, something which we can use technology, or we can use a peer-led model. So we have got two examples where we are using self-verified adherence tool, which has also given us good result. And then we have got treatment buddies and peer-led model where we are using more outreach, community-led outreach, where, they are reaching out and providing that package of services. So we can use, I think, technology as a augment to leverage, so that wherever we need that human touch, I think we use it more in an optimized manner, because we all know that, as we are scaling up with ART center, going more with the link ART center, it may be very difficult for us to place human resources everywhere. So I think it is time when we think of you putting self-verified adherence as a first line for, very adherence tool in the program. So I think we can see what is that. We have already have evidence of kind of good adherence rate and viral load suppression on those, at least. It's not the endline thing, but still we have a good thing. So we can think of moving forward, how can we leverage this technology for, improving adherence. And I think verbal autopsy, there's a lot of learning. I think there's a rich data there. One thing which was still very concerning was 51% was like HIV associated death, but cause was not known. It makes us to think, do we need to look at more kind of diagnostic tool? Is it advanced disease? Is it like, still like in when the CD4 count is low, we have got newer technological tools. Where do we now use them for, looking at early diagnosis of be it TB, be it cryptococcal meningitis? So do we need to have those kind of early diagnostic tools? I think this is a thought which I think came to me, that we need to explore the possibilities of, because we have a lot of data related to advanced disease. So do we require more diagnostic tools, some kind of thought process to be gone there? Verbal autopsy, I think they talked about the need for NCD, hypertension and diabetes. I think we're also working very closely with WHO, and GHU also is creating model in field level to look at, how we can integrate at systems. And I think that's the area which we have committed to program, that we will support you in that. A lot of talk about cervical cancer and breast cancer. I think I was also talking to, I think it was Abhina who raised it in the morning. So I think there's a need to look into it, and we can work together on that area. I think there's a lot of data which has been thrown through verbal autopsy, and it is highlighting a lot of the need of the community, which we know that, as the disease is progressing, people are living longer. So that malignancy and cancer piece, which we can look what are the areas which can be addressed through the program or through linkages. Alcohol and tobacco was another thing which he highlighted. I think behavioral interventions, we don't have any specific for, we do have like tobacco control, but alcohol is an area which I think maybe we may have to explore something in that area. Do we address that in some kind of a like linkages to some de-addiction centers, or those can be thought for us to for a long-term solution? How can we standardize, or how can we institutionalize the verbal autopsy? I think two things came. I think Manish also said like kind of a checklist and then add it to that. Or we can, we all know that in medical college, under PG, postgraduate teaching, death audit is something which is part of it. So at least in those IRT center which are part of medical college, we can think of doing that in some kind of a regular manner. I think for OVC and adolescent, lot of learning there. And we heard, I think those two girls, Ria and Valentina. I hope I got the names correct. Ordnena. Yeah, sorry. So Ordnena and Valentina, I think they gave whatever that requirement in those 5 minutes, much more. I think we understood, the whole concept of their, it's a complex issue of psychosocial needs, and then the special customized needs for adolescent. I think we need to look at that package of services which is there as a part of program, and look of, how we can expand. Because I know at least in states like Manipur and Mizoram, they have come up and said like, we need more adolescent friendly and stuff. So how do we expand from where we are now? I think these are some of the points which I have jotted down. Thank you. Over to you.
Thank you. So now, Dr. Sai Prasad.
Thank you, sir. I really, yeah, I'll be very, very short actually. I really congratulate all the speakers for their wonderful presentations on different thematic areas. Parthasarthi, sir, have been the support that you have provided for second and third 95 was quite comprehensive, from providing support for treatment initiation, prompt response, maybe adherence counseling, enhanced adherence counseling, as a preference. maybe for viral load surge testing, and it was amazing. And then the thing that really helped as a learning in terms of um, home delivery of ART. That is, that cannot be a routine practice, but can be used in cases where there are tough situations like COVID response and all, and it really helped in that way to provide treatment to the people. Regarding verbal autopsy, this we see that most of the deaths are still in the age of 40 to 50, actually, sir. And the deaths due to HIV, TB co-infection was 24% and undiagnosed was near to 50%. Sir, undiagnosed may be uh, mostly cases were from CNS and chest infections, and we never know they are due to either TB meningitis or some extrapulmonary or some infections related to TB. So uh, the uh, the focus of the program still lies on giving TB preventive treatment in the initial duration of the treatment, and also for a screening also importance on very development of the monitoring tools which will help in identifying these signs and symptoms in very early stage, and not push the patient to an extreme step where actually he was diagnosed late and he died of the cause where it was preventable that way. So the findings were very crucial and will help the program in a lot of way. Uh, for private sector engagement, the findings were very good. We see that it is, yes, it is implementable, but they should be like scalable in the implementation that way. The final the thing that we saw in OVC is that you have supported almost all the cross-cutting areas in providing support in the OVC project, and accordingly we do understand that the child-friendly areas in the AIT center are very important. Maybe we also need to understand that we need to have innovative um, adherence monitoring tools, and maybe we need to have innovative adherence counseling strategies for children, because we have seen that viral load suppression is not very good, though the testing was also not very good in children. Mein thoda sa kam dikh raha tha testing actually, but viral load suppression also need improvement in that age group. So that was all from my side on programmatic perspective that we can take away and help in improving the program.
Okay, so I think we have reached the end of this session. So there has been enough of summarizing and concluding of what has gone in the presentation and what is the expectation of the program. I'd just like to say just two things. We learned a lot from this new, I mean, there are many things which were not there in the program, and the way they have been done is definitely going to throw some light on how to modify certain small strategies to achieve big gains. That is one very good thing we learned, be it second 95, third 95, the new initiatives for VA or private sector engagement, and how to take it forward. We have just seen a very good picture of what has gone right. I would like to hear more from Manish and Jalpa and Subhash later on, maybe not here, on what didn't go right and what was our expectation and what was the constraint on behalf of the staff and in the system, which you tried to correct through certain other ways. This is one thing probably we'll have to discuss at length before we look at ways of subsuming these activities in the program or looking at ways of scaling up these activities to other centers. So I think we have had a wonderful session. though the buzzword that's coming out in all the sessions is look at mental health issues. And that is a buzzword which every session, be it prevention, testing, or treatment, or innovations, or whatever, we're just talking about that issue. It's coming out very loud and clear that that is one area where we'll have to focus, irrespective of the age group, irrespective of the system or the geography where we are working. So with this, I thank you all for patient hearing. I hand over to the.
So,
Thanks to all the speakers and to all the panelists. And special thanks to Dr. Rita Prasad and Sai Prasad for summarizing it. So I will not make many comments. Only thing is that there is a gap between the service provider and the clients, PLHI. To reduce that gap, treatment literacy is very good option which is being done. And I have seen it, and we can take it further, and we need to take it further. Without this, we cannot do it. Because a patient, PLHIV, thinks that he is alone, but when he comes on that platform, he will come to know that he is not alone. There are many others. They are facing that problem, and they are talking to each other. They are not only learning about what all are side effects, how to continue, and that definitely improves the adherence. And I've seen it. And it gives the result. So that needs to be scaled up, and we can do it. SWA is also a scalable model, definitely. But for that, we need the support may be required for the software support may be required, but it is a scalable model, no doubt. If not at the national level, but at the some of the state level, we can take it forward. We can think of, but now it needs to be done. It has shown a good result. So and all other models are also very good, and we look into whether scalability is there or not. Verbal autopsy is one thing wherein we have come to know that although the sample is very limited, until unless we have a bigger sample, then only we will be able to talk about the result. But actual thing is that the whatever is coming out of this result, that is glaring, and we need to look into it. That either many of the deaths are not being diagnosed. There is no diagnosis. That is a very glaring thing. So that we need to do something on that. So that is some action is required. So thank you, and thanks.
So I will, sir, with your permission, as the chair for the treatment session and treatment in general in NACO, I will request you to please remain on stage. We have just one more, the beginning of our concluding. Yes, sir, please.
Hindi from Karnataka, she has joined. She was not a part of any of the sessions of the
She will be joining us now. Yes.
Thanks, sir, for joining back.
So I will just take this. I know the dais is fairly packed, but in any fashion that you can. So we will be just releasing some of the treatment literacy materials. So Shri Alok Saxena ji, Shri Naveen Kumar, and I will also request Ms. Leelavati, PD Karnataka SACS, and Dr. Narendra Kumar Gupta, APD Bihar SACS, and Dr. Shobhini to please join us. We have the magical remote back. Please. So those who are already there, please remain as you are, sir, please. Those who are already there, please remain. We're just adding some more dignitaries. Lights. So we will, so with Accelerate, we have collaborated with community members to develop treatment literacy materials. We'll be sharing exactly what kind of products it is that we have been developing, but we will request you to please release the material once the lights go down. And sir, I think you already have the magical remote. No? So we will request you to please press the magical button in the magical remote. Yes, thank you.
मैं अभी HIV को बहुत पीछे छोड़ती हूँ। मेरे लिए अब उसका कोई जगह नहीं है, तो क्योंकि मैं ट्रीटमेंट ले रही हूँ तो मुझे उसका कोई डर नहीं है। मेरा नाम पूजा मिश्रा है, मैं मधुबनी जिला की रहने वाली हूँ। ART सेंटर पहुंची तो मैंने वहाँ अपने जैसे बहुत सारे लोगों को देखा जो मेडिसिन लेने के लिए लाइन में लगे हुए थे, सब एकदम खुश थे। तो मुझे वहाँ से बहुत ज़्यादा मोटिवेशन मिला, मुझे बहुत हिम्मत मिली कि अरे नहीं, मैं तो अकेली नहीं हूँ, मेरे जैसे तो बहुत सारे लोग हैं। मैं चुपचाप काउंसलर के पास जाके बैठ गई, तो मैंने उनसे पूछा भी कि मैम ये इतने सारे लोग दवा लेते हैं? तो काउंसलर ने बताया, हाँ देखिए आपके जैसे कितने सारे लोग हैं जो मेडिसिन ले रहे हैं, दवा लीजिए और पॉजिटिव सोचिए, ये आपको बहुत आगे तक लेके जाएगी। तो सेम मैंने वैसे ही किया, काउंसलर का बात माना और मैं इस आगे आ गई।
और मैं बलसार गुजरात से हूँ।
मेरा नाम सुनील गोस्वामी है और मैं भावनगर गुजरात से हूँ।
मैंने ऐसा ठान लिया कि नौकरी के साथ ही अपनी पढ़ाई कंटिन्यू रखी। मैंने BA कंप्लीट किया, फिर मैंने MSW भी कंप्लीट किया। फिर बाद में मुझे भी ऐसा लगा कि मैं HIV पॉजिटिव लोगों के लिए काम करूंगी और अभी मैं GSNB प्लस संस्था में जो 12 आश्रम चल रहा है उसमें मैं गृह माता की पोस्ट पे काम कर रही हूँ बच्चियों के साथ।
ऐसे हमने भी हमारा फ्यूचर प्लान बनाया है कि एक अच्छा सा छोटा सा एक घर बनाए और हमारा एक छोटा सा एक बेबी हो, कोई HIV पॉजिटिव हो वो शादी कर सकता है। जो आपका वायरल लोड अनडिटेक्टेबल होगा तो आप अपनी फैमिली प्लानिंग भी कर सकते हो और आपका बच्चा भी नेगेटिव आ सकता है।
Guys, I will just be handing over, if you can have the lights on, please. I'll be handing over some of the materials in hard copy as well. Thank you. Another round of applause, please, for this material. A lot of work has gone into developing this. Thank you to the treatment team and Accelerate, Dr. Manish, and of course, our community members and CPI Plus. Thank you so much for this support. And thank you for all the dignitaries for launching this, for releasing this material. So we'll now proceed to the final discussion for today. I will hand over to Chief of Party, Dr. Sunil Solomon.
Good evening, everyone. I think we're down to the last session. So I'll ask Shalok Saxena to please stay on the dais. Can I invite Janab on, please? And Deepika, can you please join us as well? I think we've come to the end of the day, so I think we just want to end with a couple of remarks to represent the community and what they're learning, where takeaway from the day. I would like Janab to share her thoughts.
Thank you. And I will be, in interest of time, very brief as in 2 minutes. I think, sir, the biggest legacy about having you is that our communities could speak so fearlessly. And thank you. That is going to be a very big pair of shoes for someone to fill in after you dimit from your office. But I think, is it okay if I speak in Hindi? Okay. I think ये program का सबसे बड़ा अगर कोई investment है, it is all of us. I think look at it from this perspective. Those two wonderfully strong women who came and told their stories, to be able to stand in a room full of people, tell their stories and tell them with so much of power. No doubt आंखों में आंसू आए, but उनके जज्बा को सलाम. Last session. I mean, look at what we've achieved through the work that we are doing to amazing partners like the partnership with TAL to provide communities alternatives. I think in management, we learn that the more options you have, your vulnerability tends to get reduced. But I think, because I am from the transgender community, my biggest investment, which I see, is a very able team led by Aditya and Simran, who has put together this fantastic group of transgender people who are doctors, nurses, managers. And I think that is the success of our program. That is the vision of our NAC. And I think the biggest thing is, sir, we cannot afford to be compliant. And the challenge also is that compliance cannot come until the investments are continued to make. But I think under the leadership of Sunil, we've been able to bring in different donor partners into the picture, the private sector foundations. We should be able to work with it. And I only have one suggestion, sir. When you are there still in NACO and of course with your able leadership and Dr. Shobni, we should get these MOUs signed with different line ministries in terms of taking forward what our mainstreaming had achieved, so that there is no room for people to say that, okay, we want to work with MOSJ, but there is no partnership in place. So I think all of the extra needs which are the various social determinants of health shall be aptly addressed. And thank you all of you. And I'm going to end with just one line of my favorite share from Allama Iqbal, who says that सितारों के आगे जहां और भी है, इश्क में इम्तिहान और भी है. So we are ready for all of these trials and tribulations, because हर शाम के बाद सवेरा होता है. And thank you for giving me this opportunity to listen to your wonderful stories of encouragement, wonderful stories of your trials. And the most important part is that the wonderful partnership that you have made in this room and beyond. Thank you.
Thank you, Janab. Now request ma'am, please if you can share your thoughts on what you thought of the whole day session.
Thank you, sir, for giving me this opportunity. And from morning, I actually learned a lot of good practices, which definitely I'll go to my Bangalore and I'll share with my colleagues, and that will help us to work in a good way, in a good motive way. We also have few good practices in Karnataka where we do door-to-door campaign and we create awareness. We usually select those taluks which have high prevalence, and we do door-to-door campaign. And from that, a lot of awareness has been created, and testing rate also has increased in Karnataka. And in the same way, we usually practice a marriage bureau for HIV people. And in Dharwad last year, we conducted nearly that marriage bureau session, and nearly 50 couples got married. So this way, we are also having good practices. Along with that, whatever I have learned from morning, definitely I'm going to share with my colleagues. Thank you.
Thank you, ma'am. So I think now it comes to Deepika and I summarize what the big learnings were from this meeting. What are we taking forward? Since I don't remember and I don't take notes, I will let Deepika start.
Thank you, Sunil. I think we've had excellent summarization across all the panels. In the interest of time, I'm going to keep it very short, and I'll request Sunil to actually add in where I miss out important points. I think the most important message we heard today was to keep all of these models that we've heard about light, replicable, scalable, and economical. So I think this is a note to self for every single one of the models we saw today. There is great interest. The evidence is clear, but in terms of having it scaled up across the country, there needs to be that light investment model available for us to really think about. One more key theme that came across the entire day across all panels was the need for youth and adolescent voices to be heard across the board. So there needs to be a youth and adolescent focused strategy that not just looks at mental health, but at outreach engagement strategies, at a ministerial integration across ministries to ensure that we don't just pass them around like batons, right? That there is a comprehensive strategy that we're looking across for our youth and adolescents. And even the intersectionality of the risks that youth and adolescents face, I think was an extremely important reminder to us to really think in those lines. And all the lessons that have been brought to bear with regard to our virtual interventions, with regard to our testing models, AFHC model that has been implemented, all focus on our Mitra Clinic and young TGs that are accessing them, all focus and point to the fact that we need this integrated youth and adolescent strategy. So we're going to take that forward. I think one important summary again, and I'm trying to touch on the really overarching points that came out today, was about partner coordination. And we were reminded that while we are passionately working within our areas to really bring some of these models to bear, we have to think ultimately about NACO and how they can assimilate all the learnings from the different partners. So almost like an inventory of the efforts that we have undertaken, whether it's job aids that are translated in different languages. We just saw the treatment literacy material. We have all our learnings from actually integrating our, say, for example, the TG clinic that we are trying to integrate into general health systems. All of these lessons need to be compiled and they need to be given to NACO in a palatable manner. And so that partner coordination was a big thing we heard. The 360-degree focus on prevention and testing, ma'am, thank you for reminding us throughout the day that that's extremely important. We cannot afford to look at just prevention being my lane and just treatment being my lane. Because we're talking about human-centered approaches, it needs to be the same individual that's held through that entire cascade. And we're looking both at the prevention cascade as well as the clinical care cascade. Looking at dual testing across all platforms, because dual testing capabilities are coming in. So we really need to think about that. Integrating STI prevention services across all the the platforms that we are providing, both virtual as well as physical. Simplifying terminology, index testing, partner testing, spousal testing. We need to kind of bring that all together and focus on getting the maximum yield from our engagement with positive individuals and making sure that we understand their social injecting networks. Somebody brought up the issue of semi-urban and rural populations and how are we engaging them on our virtual platforms is something that we need to look at. I think Rajesh really pointed to the fact that there are such specific apps that are are available, and they're tailored to regions, tailored to populations, tailored to religious groups, that we really need to keep an open mind and really start thinking about what we can do to expand that umbrella and expand the populations that we are covering within. We definitely need better linkage with 1097. I think one theme that we're continuing to hear is institutionalization, is sustainability. So how do we drive that sustainable change by ensuring that the platforms that NACO has developed should be further strengthened and capacitated so that whatever we are doing can be then handed over, essentially. Private sector engagement, actionable data that the verbal autopsy analysis has actually given us, and we've had an extensive discussion about that, so I'm not going to go into that. So I think, and last, I just wanted to touch upon the social protection schemes that a lot of our programs and our models are trying to provide. There is a need, we heard very clearly, to consolidate that information. USAID has a partner that's really looking at an online inventory of all social protection schemes available across ministries within a state. It's called Hak Darshak. You may have heard of that. And we'll try and see if we can actually, the platform is available. We just need to contextualize it and hand it over to, our various states. So there are some really, really good learnings that we can bring to bear. And I'll hand over to Sunil if there's anything that I left out. I know there was a lot of rich discussion and I can't do justice to it in 2 minutes. So I'll give it over to Sunil. Thank you.
Thank you, Deepika. So I've actually made several mistakes in my life. And one of the biggest mistakes was I shared my points with her today. So she basically covered like all the points. I really have nothing more to add to what she said. But I think the one thing I do want to say that came out very clearly is we're not done yet. There's so much more to do. And I think the one message, a couple of messages, right? So all of us talked about adolescents and how we should do their mental health and how we should do this and how we should do that. But none of that mattered when you heard what Ornella and Valentina had to say. Like when there are hundreds of Ornellas and Valentinas in India, why are we sitting here trying to think about what we should do for them? I think what we need to figure out is how do we actually integrate them into the different TRGs and try and see, can we actually set up some kind of a TRG for adolescents, both positive and negative? Because like Sir said, and many people have highlighted this morning, there is this whole transition happening into these virtual spaces. They're not talking to us. So how do we actually figure out what to do? So I think one thing we should think about over the next 6 months is to establish some kind of an adolescent working group or a TRG where we have negatives, positives, physical, virtual, getting them all together to try and come up with some kind of a consolidated strategy on how we reach them. The only other point Deepika forgot to mention, probably because I did not share with her, is what Apsara brought up in the morning. Right? So I think we're providing all these different services, but that one thing that we're not providing in these Mitra clinics is jobs and skills. Right? And I think what the power of the Mitra clinic is because we provide all these non-HIV services, it brings these people in from different places. And I think one thing the trans community, heard from Simran, heard from multiple people, is that job. Like, how do I find a job? How do I get a sustained income so I can prevent going from begging or selling sex? So trying to have these job fairs in these Mitra clinics may be an additional attraction to bring people in. I think the other thing that came out, which actually struck me, like, why haven't we thought of this? Was like, why can't we start like spoken English classes? Right? So that's something which we can think about starting in these Mitra clinics, which would be big draws for the community. Those are definitely two things we will go back and try to think. And I think the other thing that I also learned today is we should start bringing new people in, because Apsara is someone who hasn't really been engaged in the HIV field. This was one of our first meetings today. She actually told me during lunch, like, I want a Mitra clinic in Chennai. I will find you the corporate donor. I will find you the space. Just make it happen. Right? So I think bringing all these different people in from different places helps us actually address it, because USAID and PEPFAR, we focus in like 5 districts, 3 districts, but India is like hundreds of districts. Right? So if we want to make a difference in India, we need to figure out how we find these different people, how we leverage these other partners to really make it happen. So I will stop there and I will hand over to Sir for some concluding remarks from the day.
Actually, my throat has gone from bad to worse. So I thought जब जैनब जी ने बोला कि वो अपने इकबाल के अशार पढ़े, तो मैं आपको अब जावेद अख्तर के अब्बू के अशार सुनवाता हूँ। ठीक है। दिल को न बेकरार कर सुबह जरूर आएगी सुबह का इंतजार कर गम की अंधेरा तुम्हें दर्द है सारी जिंदगी जिसका कोई सिला नहीं दिल को फरेब दीजिए और ये हौसला नहीं और ये हौसला नहीं मुझसे तो बदगुमान हो खुद पे तो एतबार कर सुबह जरूर आएगी सुबह का इंतजार कर गम की अंधेरी
So this was, I was discussing, in fact, sharing with Vandana and Sangeeta Patel this morning what I'll do after retirement. So I'll do this. That this is actually, I was telling them I'm researching on lost music. This is one of the songs which is not available anywhere, you know. And I stumbled on this song by accident. But it was so apt for this evening. खुद पे तो what did it say? विश्वास के लिए क्या word है ना? एतबार कर. खुद पे तो एतबार कर. So of course we do not have a गम की अंधेरी रात here. That was perhaps some 30 years ago, but सुबह हमारी रोज आती है, and every morning, you know, we look for a challenge, and by this evening we need to actually surmount that. That is what I'll say. We have covered a long way. We still have a long way to go in public health, as we've said. Challenges, multiply challenges, take a different shape, but they remain there. The more we change, the more we remain same. As our quiz this afternoon showed that at one time, children were secretly having post boxes, and now they are erasing the chat history. So it is just, so that is just to show that we change and we still remain the same, while the medium change, the human nature remains same. So particularly this disease and the comorbidities around it and the stigma and shame that was, of course, obviously, happily, shame is not attached anymore. But the shame and stigma that was attached, that's still there. We need to come to terms with it. We need to move in new directions, new service delivery models, new things that, you know, what Sunil said just now and what Apsara had actually highlighted. And, you know, one thing I've been always saying, and I have this phrase called usual suspects. We need to get rid of ourselves of these usual suspects and bring, you know, new people to our program, so that new ideas and new way of doing things, you know, we get to know. Such dissemination exercises are important, and I'm really happy that it's been organized, and the learnings that we have been able to disseminate, it should continue. I was told that it is being webcast also. So maybe somebody can, where is Aditya? So your tech guy, you know, he can edit this and make it into smaller capsules, which perhaps we can share. Thank you very much.
Thank you, sir, for your guidance and for those. And with that, I will invite Sri Krishnan, also known as Krish, to deliver the official vote of thanks, which will probably take longer than the day because we have a lot of people to thank.
Good evening. On behalf of Project Accelerate team and the extended fraternity, I begin the vote of thanks by acknowledging the generosity of PEPFAR, USAID, and the American taxpayers. USAID team has been exceptionally helpful in structuring the event with their inputs and support to us. We sincerely thank them. NACO leadership and their entire team has been supportive to our efforts in implementing the project and specific to this event. We remain very grateful to you. We sincerely thank them and we express our sincere and special gratitude to Alok sir for his exemplary support to us, for initiating the grant and working along with us through this grant and helping us with this event too. As Sunil had mentioned this morning, SACS, communities, opinion leaders, and other stakeholders help us in successful implementation of the grant and Project Accelerate specifically. Some of them were part of today's event, and I sincerely thank them on behalf of Project Accelerate. Subhash has given me a list. I'm going to read through it. It's IPPF, SATI, FHI 360, NCTP, Plan, Infosem, NCPA Plus, HST, Alliance, RAGE, GSMP Plus, Everwell, Share, IQVIA. Of course, we respectfully acknowledge the presence of SACS here, AP SACS, Maharashtra SACS, Mumbai RACS, Telangana, Manipur SACS, and Bihar SACS. With Karnataka SACS, of course. Thank you. Before I leave, I also want to thank each one of them who made this event possible. Without them, this wouldn't have worked, because I know the efforts that went on prior to this event happening today, and I want to sincerely thank each one of them for this. And I want to also thank each one of you for understanding this is a work in progress, and this is not the end of the project, like Sunil and Deepika and Aditya reiterated. So we'll still come back, and we hope we'll be here for some more time with Project Accelerate. Thanks all of you. Thanks for your attention.